Hello. Namaste to all the lovely doctors, Pita. And if we take a look at the revision of oncosurgery, how MCQs will be framed from this area, there can be questions from GI malignancies, urology malignancies, thyroid, and breast cancers. And they can ask you about the genetic stories, they can ask you about the risk factors, they can ask you about the clinical presentation, like in breast cancer, PUD orange and dimpling, right? That is something which is common there. Then uh, they can ask you about the spread of these cancers, that how this particular cancer is going to which area. They can ask you about the investigation of choice or maybe next step. Now, investigation of choice to diagnose the cancer, to stage the cancer, then how you can do the staging, though staging is generally very rarely asked in the FMG exams. But yes, some cancers where the staging is important, we'll be talking about that. And then what should be the treatment of that particular cancer and what can be the prognosis of cancer. And in breast cancer, they also have asked about genetic analysis, when it should be done. Right. So let us take a look first with the GI cancers, and we'll be starting from the mouth to the anus. We'll be talking about oral, esophageal, stomach cancers, colorectal cancers, anal cancers, gallbladder, pancreatic cancers. But we don't discuss too much about the duodenum, jejunum, ileal cancer because continuous peristalsis does not allow the carcinogens to stay there. So there, duodenum, jejunum, ileal cancers are very rare. Right, so starting with the oral cancer beta, most commonly it is a squamous cell carcinoma. All the lovely doctors, they know that whatever area is exposed outside or area near the natural opening of the body will have to have protective lining, that is squamous lining. So malignancies in the exposed areas or near the natural openings of the body will be squamous cell carcinoma. So oral cancer will be squamous cell carcinoma. In India, most common site is the gingivobuccal sulcus or maybe the buccal mucosa. But in Western countries, it is not the tobacco chewing, so it is not the gingivobuccal or the buccal mucosa, it is the lateral border of the tongue, and then that too in the middle 1/3 of the tongue. Main risk factor is tobacco chewing. However, there can be pre-malignant lesions like leukoplakia and erythroplakia. Leukoplakia is any white patch or plaque in the oral cavity that cannot be characterized as any other disease. Erythro is red. So any red patch or plaque in the oral cavity which cannot be characterized as any other disease. And erythroplakia has got 17 times more chances of malignancy as compared to leukoplakia. So whenever we see a red patch in the oral cavity, it has to be biopsied. If we look at the prognosis of oral cancer, it will depend on the stage of the cancer, that is TNM stage, where lymph node status is going to be the most important. What is the site of oral cancer? Like at the commissures, the malignancy would be likely to be more invasive type. So the prognosis would be poor. Depth of the cancer, if the cancer is going in deeper areas, definitely the prognosis would be bad. And duration of cancer, yes, if there is a longer duration, then definitely the cancer would have spreaded. But if we have to rule out of these four options, stage, site, depth, and duration, then duration can be ruled out, that it is not a direct prognostic factor. Right. If we look at the esophageal cancer, most commonly it's a squamous cell carcinoma, and in the upper 2/3 of esophagus, and in the upper 2/3, middle 1/3 is more common. But in Western countries, the game is GRD, so it is the lower esophagus, and in GRD, because of Barrett's, there is intestinal columnar metaplasia of the squamous mucosa of the lower esophagus, so we find adenocarcinoma. Risk factors for esophageal cancer: anybody who is irritating the esophageal mucosa, whether it is smoking, alcohol, smoked food, or maybe betel nut liquid, GRD, Barrett's, eclasia, Zenkus, human papillomavirus, radiation exposure, tylosis of the palm soles, or a syndrome, Peterson Kelly syndrome or Patterson-Brown-Kelly syndrome, Plummer-Vinson syndrome. This is basically iron deficiency, glossitis, and esophageal webs. Iron deficiency anemia is associated with cholionicia, spoon-shaped nails. Esophageal webs, they are in the upper esophagus, cervical esophagus, neck portion of the esophagus. And this Plummer-Vinson is common in middle-aged females and it causes post-cricoid squamous cell carcinoma. The esophageal cancer generally grows as a polyp in the lumen of the esophagus, and this is going to cause dysphagia, initially for solids and gradually for both solids and liquids. In eclasia, dysphagia is initially for liquids and gradually for both solids and liquids. And the simple reason, in eclasia, it is the lower esophageal sphincter spasm. So when the solid food goes down, it can relax the lower esophageal sphincter muscle and solid can go down. But liquid will not be able to relax that spasm lower esophageal sphincter. So that is why it is opposite in case of eclasia. Otherwise, whenever there is any mechanical obstruction, maybe a tumor sitting in the esophagus or maybe a stricture in the esophagus, definitely there will be dysphagia for solids. Whenever there is a traffic jam in the esophagus, there will be regurgitation, which will increase the risk of aspiration and pulmonary complications. And if recurrent laryngeal nerve is involved in esophageal cancer, it will lead to hoarseness of voice. All the cancers can present with anorexia and weight loss because tumor cells produce cacaxins, which are responsible. Now, in this dysphagia patient, we can go for a barium swallow initially if we are not suspecting esophageal cancer. And on barium swallow, we can find a filling defect because here would be the tumor. So the contrast will not be going inside the tumor. So contrast is flowing through the side of the tumor, right? And this is a filling defect. This is the rat tail appearance. This rat tail can also be seen in eclasia cardia. But in eclasia cardia, there will be a sharp tapering, bird beak or pencil tip appearance, which is not seen in cancer. Rat tail can be seen in both cancer as well as eclasia. But if you have to choose for rat tail, cancer esophagus is a better answer. Also, sometimes we can see an apple core deformity in esophageal cancer, though it is commonly seen in colon cancer. So colon cancer will be a better answer. But conceptually, any tubular structure in the body, if there is circumferential cancer, then the contrast will be going through the lumen, and because of cancer, the lumen will be irregular, looking like a apple core. Now, if you are suspecting esophageal cancer, then endoscopy, upper GI endoscopy and biopsy would be the investigation of choice. You can easily take a biopsy and you can prove it's a squamous or adenocarcinoma. To stage the esophageal cancer, in the local area, we do a CCT of the thorax and the abdomen. But when we have to know about the depth of tumor, for the depth of tumor, endoscopic ultrasound is better. Like endoscopic ultrasound can show us that suppose this is the mucosa area and there is a tumor here. Now behind the mucosa is the submucosa and then comes the muscle layer and then there would be adventitia. So depending on whether the tumor is going in the mucosa or it is going in the submucosa or it is going in the muscle, endoscopic ultrasound would be a better investigation for depth of the tumor for esophageal stomach as well as colorectal cancer. For metastasis, we do a PET scan and the isotope used in PET scan is 18F-FDG, that is 18-fluorine fluorodeoxyglucose, which has got a half-life of 120 minutes. In PET scan, we give this 18F-FDG isotope. It will be taken by all those areas in the body which require more amount of glucose. So any mitotic activity in the body will be requiring more glucose. And when we do a whole body CT, we can see these golden shadows. Like this will be esophageal cancer with a lymph node nearby, with another lymph node here and a suspicious lymph node here. If the cancer would have gone into the lungs, then this would be appearing somewhat like this. If the cancer would have gone into the liver, it would be appearing somewhat like this. So that is how whole body CT tells us that what are the areas where we are suspecting the cancer. So for metastasis, we are doing this. Now, once we have done all the investigations, we can do the staging of cancer. In GI cancers, generally when we talk about GI tract, Then T staging is for the depth of tumor, N staging is for the number of lymph nodes, and M is for metastasis. T1, T2, T3, T4, T4A, T4B, N1, N2, N3, and M1. Submucosa, muscle, adventitia, adjacent organs. Pleura, pericardium, diaphragm, trachea, bone, aorta. 1 to 2, 3 to 6, 7 or more than 7, and metastasis. By this we come to know whether it's a early stage cancer or advanced cancer or metastatic cancer. We can use various prefixes in cancers like C, Y, P. C is when we are doing a clinical staging, that is when the patient came to us and we did the clinical examination, we did all the investigations, that is a clinical stage. If suppose clinical stage suggests it's an advanced cancer, so we should give neoadjuvant therapy first to downstage the tumor and then do the surgery. Then after giving neoadjuvant therapy, again we do the investigations. Now whatever is the stage, that is after neoadjuvant therapy, so we use the prefix Y. And when surgery has been done and the specimen is sent to the pathologist, now pathological staging what is done, we use the prefix P. We can use various suffixes like X and 0. X where we cannot assess, and 0 that means there is no evidence. So T0 is no evidence of tumor and you are confident about it. R0 is you have done the surgery and after surgery there is no residual tumor. The mainstay of treatment for esophageal cancer is surgery, where we remove the tumor along with the margin. The proximal margin to be taken in esophageal cancer will be 10 centimeters and the distal margin to be taken will be 5 centimeters. Because we have to take 10 plus 5, 15 centimeters as a margin. The total length of the esophagus is 25 centimeters. So majority of the times we'll end up in doing a total esophagectomy. Generally, we are doing a Ivor-Lewis operation where we do a transthoracic esophagectomy, and then esophageal reconstruction is generally done by mobilizing the stomach. So the blood supply of this stomach reconstruction is derived from the right gastroepiploic and the right gastric arteries. Now, early complication of these surgeries would be anastomotic leak, which can lead to mediastinal pulmonary complications. Late complication will be stricture at the anastomotic site. Chemotherapy, which can be used in esophageal cancer, 5-FU and cisplatin. Any therapy given before the main therapy, neoadjuvant. Any therapy given after the main therapy, adjuvant. If we look at stomach cancer, it will be adenocarcinoma. Most commonly, prepyloric region. In Western countries, cardia of the stomach. The risk factor for stomach cancer: smoking, alcohol, salt, pickles, smoked food, canned food, less vitamins, antioxidants. Bacteria, Helicobacter pylori is the main culprit. Epstein-Barr virus can cause stomach cancer. HPV can cause oral cancer and sometimes even esophageal cancer, anal cancer, cervical cancer, HPV, right? So area near the natural openings of the body, HPV is a common culprit for cancers. But stomach cancer, it is not HPV, it is EBV. Then various pathologies in the stomach, like different types of gastritis. Type A, that is autoimmune or atrophic gastritis. Type B, that is bacteria, H. pylori. Then Meniere's disease, where there is gross hypertrophy of the gastric mucosal folds. Then reflux gastritis, whenever we are doing a gastric surgery, and if we are connecting the jejunum with the stomach, then jejunal alkaline contents will reflux into the stomach, and they will cause reflux alkaline gastritis, which can lead to intestinal metaplasia of the stomach, and this can progress to cancer of the stomach. Then gastric ulcer should be considered as malignant unless proven otherwise. Adenomatous polyps in the stomach can lead to stomach cancer, and genetic mutations like P53, SMARCA1 and ROA. Pathologically, if it's a diffuse gastric cancer, अगर पूरे stomach में cancer है, तो the lumen will get narrowed, and this appears as leather bottle stomach or linitis plastica. This is a diffuse gastric cancer. Gastric cancer can be classified as early and advanced. The Japanese people, they classified this early gastric cancer, and the Borman classification for advanced gastric cancer. Now, the basic difference between early and advanced gastric cancer is the involvement of muscle. Till the time the story remains confined to mucosa, submucosa, it is early. But as soon as the story goes from mucosa, submucosa into the muscle, that is advanced. Lymph node involvement does not decide early or advanced. This lymph node involvement can be seen in both early and advanced. If there is stomach cancer, it can bleed, as we know. Tumor anywhere in the body. It is not only the growth of the cells, but also the growth of the blood vessels, which can break, lead to bleeding. And these stomach cancers can present either as hematomasis or maybe melena, more often melena. Or there can be epigastric mass as well. There can be anorexia, weight loss. We can find Trousseau's sign in stomach cancer. Certain cancers produce substances which changes the property of platelets, which increases migratory thrombophlebitis. Most common in pancreatic cancer, but can be seen in gastric cancer also. So this migratory thrombophlebitis in cancers is called as Trousseau's sign of cancer. This is different from the Trousseau's sign what we see in medicine. If we look at the spread of stomach cancer, any carcinoma can spread locally or through lymphatics or through blood. Stomach cancer can also have a direct peritoneal spread or transcoelomic spread. Locally, the game starts from mucosa, goes to submucosa, muscle, subserosa, perforate the serosa and adjacent organs. Proximal stomach cancer will involve the spleen. Distal stomach cancer will involve the pancreas. Lymph node, foregut will be going to celiac. Midgut cancer will be going to supramesenteric. Hindgut cancer to inframesenteric lymph node. So stomach cancer will be going to celiac lymph node. Now, this stomach cancer can also spread to the left supraclavicular lymph node, which is called as the Virchow's node or the Troisius sign. If stomach cancer goes to the axillary lymph nodes, that is Irish lymph node. Now, through blood, stomach cancer can go to liver and lungs, and direct peritoneal spread or transcoelomic spread if the cancer cells break from the stomach and they're getting deposited anywhere on the peritoneal surface. This is peritoneal seedlings or deposits. If these stomach cancer cells are depositing around the umbilicus, periumbilical tumor deposits, hot MCQ, Sister Mary Joseph nodule. These gastric cancer cells depositing on the functional ovary, this is Krukenberg tumor. These tumor cells depositing on the anterior rectal wall, this is Blummer's shell. Our clinical approach, if the patient presents with melena, then first we have to do a stool for occult blood. And if malignant cells are present and it is melena, it is not a lower GI bleed, it's a upper GI bleed. So we should do a upper GI endoscopy, and if there is a tumor in the stomach, we can take a biopsy. If a patient presents with epigastric mass, first we do ultrasound, and if we find a tumor in the stomach, we can do endoscopy and biopsy from this stomach tumor. For staging of stomach cancer, we do CECT, but when we have to see the depth, we can do endoscopic ultrasound. And for metastasis, we do PET scan. By this, we come to know where we stand, so we can do the staging like T1 submucosa, T2 muscle, T3 subserosa, T4A perforate the serosa, T4B adjacent organs. 1 to 2, 3 to 6, 7 or more than 7, 7 to 15, more than 15, and distant metastasis. Esophageal cancer, submucosa, muscle, adventitia, adjacent organs, pleura, pericardium, diaphragm, trachea, bone, aorta. 1 to 2, 3 to 6, 7 or more than 7, metastasis. Stomach cancer, submucosa, muscle, subserosa, perforate the serosa, adjacent organs. 1 to 2, 3 to 6, 7 or more than 7, 7 to 15, more than 15, metastasis. Now, mainstay of treatment for stomach cancer will be surgery. And for stomach cancer, we take a margin of 5 centimeters all around the tumor. If the tumor is in the proximal part of the stomach, we do a total gastrectomy with splenectomy to remove the lymph nodes. If it's a distal stomach cancer, then we do a partial or subtotal gastrectomy. Colorectal cancers, most commonly the colorectal cancers, they are seen in the rectosigmoid area, because this is the reservoir where carcinogens can stay for a longer period. 38% in the rectum, 21% in the sigmoid, and then it is the cecum. It's a adenocarcinoma. The reason for colorectal cancer, dietary factors, people who take more amount of red meat, जो लोग लाल मांस ज़्यादा खाते हैं, or more animal fat exposure, less fiber in diet which will make them constipated, so carcinogens will stay for a longer period, less vitamins and antioxidants, smoking, alcohol, inflammatory bowel diseases, ulcerative colitis have more chance of colon cancer, cholecystectomy. If the bile acids are not getting stored in the gallbladder, they will be passing as such and then they'll be getting stored or maybe staying for some time in the rectum sigmoid area. Radiation exposure, mutation in APC gene, various polyps like familial adenomatous polyposis, very commonly associated with colon cancer. And this familial adenomatous polyposis, as you can see, there are numerous adenomatous polyps in the colon. This can be associated with Gardner's syndrome when FAP is associated with epidermoid cyst. It can be associated with Turcot syndrome when FAP is associated with brain tumors. Link syndrome or hereditary non-polyposis colorectal cancer can be associated with MMR gene mutation. Familial adenomatous polyposis is autosomal dominant. APC gene mutation will be there. 50% of the times there is congenital hypertrophy of the retinal pigment epithelium in familial adenomatous polyposis. If more than 100 adenomatous polyps are seen in the colon, it is diagnostic of FAP. Gardner's is FAP with epidermoid cyst and desmoid tumors, and Turcot's is FAP with brain tumors. And there is very high risk of cancer in FAP. There is familial hematomatous polyposis condition also, which is Peutz-Jeghers syndrome, where there are multiple juvenile polyps in the intestine associated with melanin pigmentation of the lips, buccal mucosa, hands, and the forearms. Right colon cancers, they generally ulcerate, so they bleed. Left colon cancers, generally they obstruct because they are annular. Rectal cancer most commonly presents with bleeding. So the commonest presentation of colorectal cancer will be bleeding per rectum, whether it is a right colon cancer or a left colon cancer. If it is right colon, the cancer cells can go into the superior mesenteric vein, portal vein into the liver. If it's a left colon cancer, cancer cells can go in the inferior mesenteric vein, then splenic vein, portal vein, liver. 33% of colorectal cancer patients, by the time they come to us, they already have liver metastasis inside. If a patient is presenting with bleeding per rectum and we are suspecting colon cancer or rectal cancer, then we should do whole colonoscopy. Complete colon should be evaluated and we can take a biopsy and that will diagnose the cancer. For screening of colon cancer, we do a flexible sigmoidoscopy or colonoscopy. A better would be doing a colonoscopy every 10 years. If we are doing barium enema, then we can find this apple core appearance in colon cancer. If we look at the staging, we know if it's a colon cancer. For staging, we can do CECT. But when the story goes into the pelvic area, we do MRI. So for rectal anal canal cancers, for staging, we do MRI. But for right colon, transverse colon, left colon, we do CECT. And for metastasis, we do PET scan. The TNM staging, submucosa, muscle, subserosa, adjacent organs, 1, 2, 3, 4 or more than 4, and adjacent distant metastasis. Now, if we look at esophagus, stomach, and colon cancer, esophagus, submucosa, muscle, adventitia, adjacent organs, pleura-pericardium, diaphragm, trachea, bone, aorta, 1 to 2, 3 to 6, 7 or more than 7, metastasis. Stomach cancer, submucosa, muscle, subserosa, perforate the serosa, adjacent organs, 1 to 2, 3 to 6, 7 or more than 7, 7 to 15, more than 15, metastasis. Colon cancer, submucosa, muscle, subserosa, adjacent organs, 1 to 3, 4 or more than 4, metastasis. In the treatment, the mainstay of treatment is surgery. In colon cancer, we take a margin of 5 centimeters. So if it's a right colon cancer, we do right hemicolectomy. Left colon cancer, then we do a left hemicolectomy. if the cancer is more towards the hepatic flexure of colon, then we do extended right hemicolectomy. While in rectal cancers, we take a 2 centimeter margin all around the cancer. And in rectal cancer, especially in the lower rectal cancers, if even 1 centimeter of distal margin can be obtained, that is also adequate. In rectal cancers, if suppose this is the rectum here and this is the anal canal. Cancer in the upper rectum, we can take a 2 centimeter margin, that is anterior resection. Middle rectal cancers, we can easily take 2 centimeter margin, low anterior resection. Cancer in the lower rectum is a problem. So here we prefer endoscopic circular stapler. Endoscopic circular stapler sphincter preserving surgery. And even if we get 1 centimeter distal margin, wonderful. If we cannot take even 1 centimeter of the distal margin, then we have to remove the entire rectum and the anal canal, abdominoperineal resection. And once this rectum anal canal is gone, then the sigmoid colon is taken out on the abdominal wall as a permanent sigmoid colostomy. Right, and this is how we can put a colostomy bag. For prognosis, it depends on the stage, TNM, and in TNM, it is the lymph node status which is most important. Anal canal cancers, they are linked with human papilloma virus. There will be squamous cell carcinoma, and obviously the skin of the perineal area and the lower limbs, they will be draining to inguinal lymph nodes. So anal cancers will be going to inguinal lymph nodes, the superficial inguinal lymph nodes, right? So it is the superficial inguinal lymph nodes which are going to be more commonly involved. And in the treatment for anal canal cancers, if we have to do surgery, we have to do abdominoperineal resection with permanent sigmoid colostomy. But nowadays, we can treat these anal cancers without surgery by giving a combination of chemotherapy and radiotherapy. This chemoradiotherapy is Negro regime for anal canal cancers. The chemotherapy which we can use in colorectal cancer is 5-FU and oxaliplatin. Targeted therapy in rectal cancer used is cetuximab. If we look at gallbladder cancers, most commonly they are seen in the fundus of the gallbladder. There will be adenocarcinoma, and the main risk factor is the gallstones. However, porcelain gallbladder, adenomatous polyp, typhoid carriers can lead to gallbladder cancer. Patient can present with cholecystitis or maybe right hypochondrial mass or maybe jaundice. And because we cannot take a biopsy from the gallbladder cancers because no endoscope can go inside the gallbladder, so it's better to do a CECT. Percutaneous biopsies as far as possible are avoided to avoid risk of spreading of cancer cells. And in the treatment, we do a radical cholecystectomy where we remove the gallbladder along with the lymph nodes. This is the tumor inside the gallbladder. Pancreatic cancers, we can find pancreatic cancers either in the head of pancreas or in the periampullary region. Either in the head of pancreas or periampullary, head pancreatic cancers are much more common, and there will be adenocarcinomas. The risk factors would be smoking, chronic pancreatitis, diabetes, and hereditary. In pancreatic cancers, generally the patient will present with jaundice. However, jaundice will be late but progressive in head pancreatic cancers, while jaundice will be early and waxing and waning type in periampullary cancers. There is marked weight loss in pancreatic cancers, and a Courvoisier's law says that gallbladder is always palpable if CBD obstruction is due to cancer. Gallbladder will always be palpable. But gallbladder may not always be palpable if CBD obstruction is due to stone, because this stone might have slipped from the gallbladder, and if the stone was present for a long time in the gallbladder, it might have caused chronic inflammation of the gallbladder, because of which healing fibrosis, and fibrosis would have led to narrow contracted gallbladder. For pancreatic cancers, if we look at the investigation of choice, we can easily do ERCP and biopsy from periampullary cancers. So ERCP biopsy is for periampullary cancer, but we will not be able to do ERCP and biopsy for head pancreatic cancers. So here it is the CECT of the abdomen. However, now a lot of people are doing endoscopic ultrasound guided biopsy from these head pancreatic cancers. If you have to choose in your exam, CECT first. If not given, then endoscopic ultrasound guided biopsy. That is the investigation of choice for head pancreatic cancers. Tumor marker for pancreatic cancer, it is CA19-9. The second tumor marker for pancreatic cancer is CEA, carcinoembryonic antigen. Tumor marker for colon cancer is CEA, carcinoembryonic antigen. And the treatment for pancreatic cancer, whether it is a head pancreatic cancer or periampullary, because pancreas is fused with the duodenum, so we have to remove this head of the pancreas along with the duodenum. Nowadays, we are doing a pylorus preserving pancreaticoduodenectomy. And after removing the head of the pancreas along with the duodenum, we also remove the CBD and the gallbladder in this. So, we take the jejunum and we do a pancreaticojejunostomy, hepaticojejunostomy, and a pylorojejunostomy. Earlier, we were not preserving the pylorus. We were actually chopping the pylorus also. So we were doing a pancreaticojejunostomy, hepaticojejunostomy, and a gastrojejunostomy. The problem was because pylorus was not preserved, so pancreatic juice and bile, they used to reflux more in the stomach and they used to cause more damage of the residual stomach. So now we are doing a pylorus preserving pancreaticoduodenectomy where this pancreatic juice and bile does not reflux into the stomach easily. So residual stomach damage is less. Earlier, when we were removing the pylorus, that was called as Whipple's operation, triple bypass operation. Pancreaticojejunostomy, hepaticojejunostomy, and gastrojejunostomy. Now it is pylorus preserving pancreaticoduodenectomy. Apart from these cancers, there may be some more tumors related to GIT, like GIST, that is gastrointestinal stromal tumor. There can be gastrinoma. There can be carcinoid tumor. Now, GIST is not from the mucosa. It is from the supportive connective tissue of the mucosa, maybe submucosa or the muscle. And this GIST can occur anywhere in GIT. It originates 50% of the times from the stomach, and second most common site is the ileum. It does not originate from the mucosa, it originates from the interstitial cell of Cajal. It is associated with c-KIT gene mutation and there is overexpression of CD117. If GIST becomes malignant because there is no mucosa, the game is submucosa connective tissue. If it becomes malignant, it will not be carcinoma, it will be sarcoma. And sarcomas generally does not spread via lymphatics. So generally, we don't have to remove the lymph nodes in treating the sarcomas. This is just wide local excision, like we can do a partial gastrectomy in GIST of the stomach. Lymph node removal is not required. If suppose GIST is massive or malignant or recurrent type, then we have to give imatinib, that is marketed by the name of Gleevec, for the whole life to this patient. Gastrinoma is a gastrin-producing tumor, Zollinger-Ellison syndrome, and it is seen in the gastrinoma triangle, which is bounded superiorly by the junction of cystic duct and the CVD, inferiorly by the junction of second and third part of duodenum, and medially by the junction of neck and body of the pancreas. So this is the gastrinoma triangle where we can find these tumors, maybe in the first part of duodenum or in the second part of duodenum or in the head of the pancreas. And these gastrinomas, they may be autosomal dominant associated with multiple endocrine neoplasia 1 syndrome. They may be associated with non-beta islet cell tumor of the pancreas. These gastrinomas will be producing huge amount of gastrin, and gastrin will be stimulating the parietal cells to produce huge amount of acid, which is not only going to cause ulcers in the stomach duodenum area, but here and there in the intestine, and patient will present with abdominal pain. We can do some lab test to figure out these gastrinomas. Like best lab test would be if fasting serum gastrin level is more than 10 times the normal and pH inside the stomach is less than 2. This is diagnostic of gastrinoma. Secretin provocative test. There also we find a raised gastrin level if more than 110 picogram per ml. That is also suggestive. However, radiologically to diagnose these gastrinomas nowadays, the best is 68 gallium labeled somatostatin analog with PET CT. So this is a basically PET scan. 68 gallium labeled somatostatin analog is used in PET scan. This somatostatin analog will be taken up by the somatostatin receptors on the gastrinoma. And when we do the CT, we can see this uptake of 68 gallium somatostatin analog by the gastrinomas. We can do other radiological investigations as well, like CCT or endoscopic ultrasound. In the treatment of choice will be aggressive PPIs for gastrinoma. If suppose gastrinoma is more than 2 centimeters, then we can do removal of this tumor. Carcinoid tumor, this is a neuroendocrine tumor. This can occur anywhere in the body, like maybe in the bronchus. But when we talk about GIT carcinoids, argentophilomas, they are most oftenly seen in the appendix. They originate in the argentophin tissue, that is Kolchitsky cells of crypts of liver cone, because these carcinoid neuroendocrine tumors, so they produce substances like 5-hydroxytryptamine or serotonin, which can lead to various symptoms, maybe cyanosis, flushing, diarrhea, borborygmi, or asthmatic attacks. There would be raised levels of 5-hydroxytryptamine, that is serotonin, and we find raised levels of 5-hydroxyindolestic acid in urine. The plasma marker would be chromogranin A. In the treatment for appendiceal carcinoids, then there what we can do, we have two options. Either we do just appendicectomy, just chop the appendix, especially if the tumor is less than 2 centimeters in size, no involvement of cecal wall, no involvement of lymph nodes. But if the tumor is 2 or more than 2 centimeters in size and involving the cecal wall or the lymph nodes, then we prefer doing a right hemicolectomy. Treatment for ileal carcinoids, the first choice is somatostatin analogs, and the second choice is PRRT, that is peptide receptor radionuclide therapy. From the GI tumors, we move to the urinary tumors: kidney, bladder, prostate, penis, and testis. Now, in kidney, we can find a tumor in babies also, that is a Wilms tumor or nephroblastoma. In adults, the renal cell carcinoma is hypernephroma. In babies, this Wilms tumor or nephroblastoma, this is the most common tumor of childhood, especially less than 5 years of age. And this can be associated with inactivation of Wilms tumor suppressor genes, WT1, which is associated with the Weger syndrome and Dennis-Drash syndrome. Inactivation of Wilms tumor suppressor gene 2, WT2, back with Wiedemann syndrome. Generally, Wilms tumor is common on the lower pole of the kidney, and in babies, if there is a tumor in the kidney, baby will present with an abdominal mass in the lumbar region. Sometimes there can be pyrexia, there can be hematuria, because we cannot put any endoscope in this area, because the endoscope can go only up to this area. So we cannot do a endoscopic biopsy, and we don't want a percutaneous biopsy because of risk of spillage of cancer cells. So investigation of choice will be CECT, where we can even see a claw sign. Right. In the treatment for stage 1, stage 2 Wilms tumor, surgery plus chemotherapy. For stage 3, stage 4 Wilms tumor, surgery, chemo, and radiotherapy. Surgery, what we are doing is a radical nephrectomy, where we remove the kidney along with the lymph nodes. Adult kidney cancer or hypernephroma, This is a adenocarcinoma which originate mainly from the PCT epithelium. It's a clear cell type. And kidney and bladder cancers, they are most often related to smoking because toxins in smokers, they are excreted through the urinary tract, exposing the urinary mucosa for a long period of time. Kidney bladder cancers are also called as industrial cancers or occupational cancers because people who are working in different industries, maybe industries related to dyes, chemicals, textile, rubber, polish, carpenter, painter, or people who are working in industries where aniline dyes, naphthylamine, benzylene, azo dyes are used, then definitely these chemicals are getting absorbed through the skin of these patients and getting excreted through the urinary tract, exposing the urinary mucosa to these harmful chemicals. Long-term analgesic use, long-standing stone disease in the kidney, and a von Hippel-Lindau syndrome, which is associated with mutation in VHL gene located on a short arm of third chromosome. Now, whether it's a kidney cancer or bladder cancer, generally patient presents with painless hematuria. However, kidney cancer patient can present with a mass in the lumbar region, there can be a pain in the lumbar region, and left-sided kidney cancers can also present with left-sided varicocele because left testicular vein opens in the left renal vein. If the kidney cancer goes into the left renal vein, there will be a traffic jam for the left testicular vein. So, the blood from the left testicular vein will not be able to go up, it will be going down, which will cause back pressure and will damage the valves in the left testicular vein. So, the blood will be pooling down in the pampiniform plexus of veins around the testis, that is left varicocele. Kidney tumors, kidney cancers can produce substances which can lead to paraneoplastic syndromes, like there can be hypercalcemia, erythrocytosis, and raised ESR. Whether it's kidney or bladder cancer, if painless hematuria is there, first we have to do a urine cytology to rule out malignant cells. If malignant cells are positive in urine, it can be a bladder cancer, it can be kidney cancer. Because bladder cancer is more common, so we should do a cystoscopy. But if it is not a bladder cancer, you will not find anything on cystoscopy. Then you suspect kidney cancer, so you can do a CECT. And a CECT will be the investigation of choice. Because the same story, endoscopic biopsy will not be possible. And in the treatment for adult kidney cancers or hypernephroma, the mainstay of treatment is surgery. Adult kidney cancers, hypernephroma, they do not respond to chemotherapy and radiotherapy. However, immunotherapy has been used in kidney and bladder cancers where we can give BCG. So, mainstay of treatment is surgery. Now, whether we should do a partial nephrectomy or a radical nephrectomy. Partial nephrectomy is the nephron sparing surgery. If the tumor is less than 4 centimeters in size, or in selected cases 4 to less than 7 centimeters in size, or if there is a tumor in a patient who is having a single kidney, or if there is a tumor in both the kidneys, or if the kidney function is impaired, then we try to preserve as many nephrons, nephron sparing surgery or partial nephrectomy. But if these are not the cases and the tumor is 4 centimeters or more than 4 centimeters in size, we go for radical nephrectomy. Bladder cancer, most commonly it's a transitional cell carcinoma, 90 to 95%, because we know pelvic calyceal ureter bladder urethral lining is transitional. Very rarely we can find squamous cell carcinomas in the bladder. That is due to schistosomiasis, parasite schistosoma hematobium. We sometimes can find adenocarcinomas in the bladder, especially when there is congenital bladder diverticula. So that is located at the dome or fundus of the bladder in midline anterior-superiorly, having that columnar lining, which can lead to this adenocarcinoma. Most commonly, the site of bladder cancer would be the lateral bladder wall and the trigone area. Risk factor would be smoking, Apart from this, various dyes and chemicals can be there. And if we look at the pathology, then generally bladder cancers are growing as papillomatous tumors. If most commonly 70% of bladder cancers, they do not invade into the muscle. So they are in the mucosa or submucosa. That is superficial bladder cancer. But when they start invading into the muscle, that is a muscle invasive bladder cancer. Sometimes we can find flat cancers also, not papillomatous but flat. They also can be superficial, not going into the muscle, or they can also be muscle invasive. Now these flat cancers, they are generally multicentric, so they have poor prognosis. Overall, most commonly we find superficial bladder cancers, that is non-muscle invasive bladder cancers. And most commonly bladder cancer present with painless hematuria. Any patient coming with painless hematuria, elderly person especially, we do a urine cytology for malignant cells first. If that is positive, we suspect bladder cancer, so we do cystoscopy. And if we find a tumor inside the bladder, then we take a cystoscopy and biopsy. And biopsy will tell us that yes, this is a bladder cancer. For staging of bladder cancer, we do MRI. Now, in the treatment, if it is a superficial bladder cancer, that is, if it is not going into the muscle, non-muscle invasive, then the treatment of choice is TURBT, that is transurethral resection of this bladder tumor. And after this, we give intravesical therapy, either intravesical chemotherapy with mitomycin C or intravesical immunotherapy with BCG. If it's a muscle invasive solid bladder cancer, then we give neoadjuvant chemotherapy to downstage the tumor. Then we have to remove the entire bladder, radical cystectomy, that is actually removal of the bladder with the prostate, so it is cystoprostatectomy. Once we are doing a radical cystectomy or cystoprostatectomy, then we have to either reconstruct the bladder, create a new bladder using ileum, or do a urinary diversion through a ileal conduit or colonic conduit. If muscle invasive bladder cancer patient is not willing for surgery, he does not want his bladder to be removed, then we can give a combination of chemotherapy and radiotherapy also. Prostate cancer is the commonest cancer in elderly males. Actually, 70% of males after 80 years of age suffer from prostate cancer. And it's an adenocarcinoma in the peripheral zone, posterior lobe. Why this prostate cancer occurs, the exact reason is not known, but is thought to be related to androgen, because androgen ablation helps in controlling this cancer, especially in advanced prostatic cancer. So, as we know, the BPH story, 5-alpha reductase overactivity, which convert testosterone to 1,5-dihydrotestosterone, which causes hyperplasia of the cells in the prostate, may be related to that. Prostate cancers, they are very slow growing cancer. Cancer ke naam pe kalank hai. So patient generally does not have symptoms, and patient may come to you with low backache. And when X-ray is done for this low backache in an elderly male, we come to know that, oh, there are metastatic deposits in the lumbar vertebra, which is causing this pain. However, if we look at the spread of prostate cancer, locally, prostate cancer spread upwards and laterally. So, involvement of seminal vesicles occur early, but involvement of urethra is late. Through lymphatics, prostate cancer, pelvic organ, so it will be going to pelvic lymph nodes, that is the internal iliac lymph nodes. And there, obturator lymph nodes will be involved first, and then the internal iliac lymph nodes. Through blood, prostate cancer spread most commonly to the bones, and in the bones, it is the lumbar vertebra. However, femur, thoracic vertebra, ribs, skull, they can be involved. There are 5 cancers which commonly spread to bones, remembered by the mnemonic PBKBT. पाकिस्तान भारत का बच्चा था. Prostate, breast, kidney, bronchus, thyroid. Most common cancer going to bones in males is prostate, females, breast. Now, these prostate and breast cancer, they go to the lumbar vertebra through a Betson's vertebral plexus of veins के through जा रहा है. Because prostate and breast both are related to hormones like androgen for prostate and estrogen for breast, so we find osteoblastic metastasis in prostate and breast cancers. However, breast cancer we can also see osteoclastic, and prostate also we can see osteoclastic, but commonly osteoplastic. Right. Investigation of choice for prostate cancer is a transrectal ultrasound guided prostatic biopsy, and we have to take 12 biopsies to diagnose this prostate cancer, and it turns out to be adenocarcinoma. The pathologist can do a Gleason's grading for prostate cancer, where the Gleason score ranges from 2 to 10. Breast cancer pathological grading is Bloom-Richardson grading. Once this biopsy proves it's prostate cancer, for staging, we do MRI, and it's a multi-parametric MRI. And for metastasis in prostate cancer, we are doing a PSMA scan, that is prostate-specific membrane antigen PET scan. And tumor marker for prostate cancer is serum PSA. Normal level of serum PSA is 0 to 4 nanogram per ml. More than 10 is suspicious of cancer. More than 35 indicate advanced prostatic cancer. And the uses of PSA can give us an idea about the risk of disease progression. It can help in diagnosing the pathologies of prostate. It can help in monitoring the response of prostate cancer treatment. And it can assess the recurrence of prostate cancer after treatment. The most important use of PSA is monitoring the response of treatment in prostate cancer, whether whatever treatment you are giving that is adequate or not. Now, what should be the treatment for prostate cancer? There are two stories. If the cancer is confined within the prostate, and suppose age is less than 70 years, where life expectancy is more than 10 years, then we do a radical prostatectomy, either by open laparoscopic or robotic surgery. Or we can also do external beam radiotherapy, where we use iodine 125, or we can use palladium 103. However, if the cancer is confined within the prostate and the age is more than 70 years, where life expectancy is less than 10 years, no need to do radical prostatectomy or radiotherapy. Just do active surveillance, because this cancer may not grow fast. And if the patient is not going to live for a long period, then no need to give complications of surgery or radiotherapy in this patient. We just do active surveillance, where we can do follow-up of this patient with MRI every 6 months. If the cancer is advanced prostate cancer, suppose it is gone to bones or here and there, then we'll not be able to remove this cancer from the patient completely, so we cannot cure this patient. In these cases, whatever life patient is having, to make that life as comfortable as possible, we do palliative treatment, that is androgen ablation. For androgen ablation, we can either give medicines or we can do surgery, where we remove both the testes of the patient to reduce the testosterone. So bilateral subcapsular orchidectomy is an option for hormonal androgen ablation in prostate cancer, but better than this surgical treatment, medical treatment, where we can use LHRH agonist like Goserelin, Bruserelin, we can use LHRH antagonist like Degarelix, androgen receptor blockers like enzalutamide, and testosterone production blocker like abiraterone. This is the robotic operation theater, where we can see these are the robotic arms from where we can put the instruments, and this is the computer console where the robotic surgeon is sitting and handling these robotic arms guided through a computer. So surgical precision is great in robotic surgery. Penile cancers are squamous cell carcinomas, most commonly at the glans papillae. Risk factor would be poor hygiene and smoking, human papillomavirus, long-standing genital warts, multiple sexual partners, Penile intraepithelial neoplasia is involving the glands is erythroplasia of Currat, involving the shaft is Bowen's disease. Clinically, patient can present with a ulceroproliferative growth over the penis, and just like anal cancers, penile cancers also present with enlarged inguinal lymph nodes. However, inguinal lymph node enlargement, 50% of the time it is because of infection and 50% it is because of the tumor. And death in penile cancer patient is because of torrential bleeding, because of erosion of the iliac or the femoral vessels by these enlarged inguinal lymph nodes. When this patient comes to us, we can take a biopsy, that is the investigation of choice to diagnose penile cancer. For staging, we do MRI, and for metastasis, we do PET scan. And the treatment of choice will be surgery. If we can take a 2 centimeter margin around the tumor and can preserve 2 or more than 2 centimeter of penile stump, then we do a partial penectomy. But if we take a 2 centimeter margin around the tumor, and if we cannot preserve even 2 centimeter of penile stump, then we do a total penectomy. So this is partial penectomy, this is total penectomy. After chopping the complete penis, refashion the urethra and the perineum, perineal urethrostomy. For inguinal lymph nodes, we give a 3-week antibiotic course. If they were enlarged because of infection, antibiotics will treat them. But if they were because of tumor, they will persist even after antibiotics, and then we have to remove those inguinal lymph nodes. Testicular cancer is the most common cancer in young males. Most commonly, it's a seminoma. And in the testes, we find germ cell tumors, which can be seminomatous, non-seminomatous. Non-seminomatous like embryonal cell carcinoma, yolk sac tumor, and teratomas. Most common cause of testicular cancer is undescended testis, and this presents with scrotal enlargement. There would be heaviness in the scrotum. There may be enlarged prepariotic lymph nodes causing epigastric lump. Hemoptysis in testicular cancer. This indicates pulmonary metastasis. Rounded cannonball deposits. Lung metastases are quite common in various cancers because ultimately cancer anywhere in the body, if it is spreading through blood, it will be going in the veins. Ultimately, if the venous blood is coming either by superior inferior vena cava in the right atrium, so cancer cells will be coming in the heart, but because heart is doing dhak, so cancer cells will not be able to stay in the heart. They'll go through the pulmonary artery into the lungs. That is why lung metastases are very common in various cancers, and we can see them as cannonball deposits. Seminomas spread more commonly by lymphatics, teratomas spread more commonly by blood, so seminomas have better prognosis. Right testicular cancer, that generally goes to the interaortocaval lymph nodes, the yellow one, while left testicular cancers more often goes to the left para-aortic lymph nodes, the green one. Now, if a patient presents with scrotal enlargement, we check for transillumination. If it's a tumor, transillumination will be negative. Transscrotal FNAC or biopsy is absolutely contraindicated because if transillumination is negative, it can be tumor, and if it's a tumor, doing a transscrotal FNAC biopsy can spill the cancer cells in the scrotum. So a better option would be to get the ultrasound of the scrotum done first to rule out whether it's a tumor or fluid. You can also take the help of tumor markers like alpha-fetoprotein raised in yolk sac tumors, HCG in choriocarcinomas, lactate dehydrogenase, and placental alkaline phosphatase, more so in seminomas. However, investigation of choice will be CECT. Another image showing how these rounded opacities can look like cannonball deposits. Right. Now, we can stage the testicular cancer if the game is confined within the testis, stage 1. If it goes to lymph nodes below the diaphragm, stage 2, lymph nodes above the diaphragm, stage 3, and distant metastasis, stage 4. Stage 2, lymph nodes below the diaphragm can be classified as 2A, 2B, 2C, up to 2 centimeters 2A, more than 2 to 5 centimeters 2B, and more than 5 centimeters 2C. If it is just stage 1, high inguinal orchidectomy will be sufficient. Like we can just remove the testis along with the spermatic cord. So we have to do a high inguinal orchidectomy. And if it's a seminoma, it may look something like this on histopathological examination. Now, if it is stage 2 or stage 3, then definitely the lymph nodes are also involved. So we have to either remove those lymph nodes, retroperitoneal lymph node dissection, or we can destroy them by radiation, or we can give chemotherapy. Seminomas respond to radiotherapy, but teratomas do not. So radiotherapy cannot be used in teratomas. Now, in stage 2 or stage 3, a better option would be giving a combination chemotherapy, that is BEP, bleomycin, etoposide, and platinum-based cisplatin. Prognosis of seminoma is better than teratoma because seminoma spread more commonly by lymphatics and teratoma spread more commonly by blood. If we look at thyroid cancers, it is a common endocrine malignancy, and malignancy in the thyroid can originate from the follicles or the parafollicular C cells. Majority are follicular cells, so majority malignancy from the follicle, which can be papillary or follicular thyroid cancer. Malignancy from parafollicular C cells, that will be medullary thyroid cancer. Metastasis can come to the thyroid from other cancers, maybe breast cancer or kidney cancer. The commonest thyroid cancer is a papillary thyroid cancer. If we see the differences between papillary and follicular, papillary is much more common and usually seen in slightly younger age group, less than 40 to 50 years, follicular usually after 50 years of age. The reason for papillary cancer is radiation to the neck, especially if multiple X-rays and CT scans are done in a child less than 5 years of age. The chances of papillary thyroid cancer developing later in life are more. Thyroglossal cyst, which moves with protrusion of tongue, this can complicate to papillary thyroid. While follicular thyroid cancer is common in long-standing endemic coitus. Pathologically, papillary thyroid cancers we find orphan aniide nuclei and psammoma bodies. This is the orphan aniide nuclei, the pale empty nuclei, pale empty nuclei. These are orphan aniide nuclei, and we can find psammoma bodies. Psammoma bodies can be seen in PSM. PSM is the mnemonic. P is papillary renal cell carcinoma, papillary thyroid cancer, pituitary adenomas. S is serous cyst adenoma of ovaries, salivary adenoma, and M is meningioma. Follicular thyroid cancers, pathologically they are encapsulated, and FNAC cannot distinguish between follicular adenoma and follicular carcinoma because FNAC cannot comment about capsular or vascular invasion. So, FNAC cannot distinguish this follicular adenoma from follicular carcinoma. Is the only difference between the two is when the capsule is invaded or the nerve vessels are invaded, then it is carcinoma. Otherwise, it's adenoma. Generally, thyroid cancer patients, whether it is papillary or follicular, they present with swelling in the neck. We do ultrasound guided FNAC, and we come to know. Papillary thyroid cancer spread more commonly by lymphatics. Follicular spread more commonly by blood. So papillary will have a better prognosis as compared to follicular. The tumor marker for these papillary and follicular thyroid cancer is serum thyroglobulin, and the treatment for all thyroid cancers is total thyroidectomy with removal of involved lymph nodes. Medullary thyroid cancers, like this is the total thyroidectomy specimen. The incision which we make for thyroid surgery is something like this, the lower part of the neck, and this is the total thyroidectomy specimen. Medullary thyroid cancer originate from parafollicular C cells. These are not dependent on TSH. Serum thyroglobulin is not the tumor marker because it is not the game of follicle. Pathologically, we find amyloid stroma in medullary thyroid cancers. This is autosomal dominant, can be associated with multiple endocrine neoplasia 2, 2A and 2B. And these medullary thyroid cancers are associated with ret proto-oncology. Patient presents with a swelling in the neck with enlarged cervical lymph nodes. Medullary thyroid cancer produces substances like serotonin. So in 25 to 30% of patients, we find diarrhea. The tumor marker for medullary thyroid cancer is serum calcitonin, and the second tumor marker is carcinoembryonic antigen. And the treatment should be total thyroidectomy with removal of the involved lymph nodes. In thyroid cancers, the first lymph node to be involved will be pretracheal. So level 6. If we look at the different levels of lymph nodes, so 1A is submental, 1B submandibular, then 2, 3, 4 upper, middle, lower, deep cervical or jugulodigastric, 5 is posterior triangle, 6 is pretracheal, and 7 is mediastinal. 8 would be parotid, 9 will be buccofacial, and 10 will be retroauricular and post auricular or maybe occipital lymph nodes. There can be different type of neck dissections what we do in oral cancers, because the entire head and neck area is going to the cervical lymph nodes. So head and neck malignancies which are going to the neck lymph nodes, we can do different types of neck dissection. Like radical neck dissection is when we are removing level 1 to level 5 lymph nodes along with sternomastoid muscle, internal jugular vein and spinal accessory nerve. Modified neck dissection is same as radical neck dissection, but preservation of one or more from sternomastoid, internal jugular vein or spinal accessory nerve. Selective neck dissection is same as modified neck dissection, but with preservation of one or more lymph nodes from 1 to 5 groups. Then, if we look at the breast cancer story, this is the commonest cancer in females. 90% of breast cancers originate from the duct. So most commonly it's an invasive ductal carcinoma, it's an adenocarcinoma. And most commonly it is seen in the upper outer quadrant, least commonly in the lower inner quadrant. Risk factor for breast cancer, they can be familial, both on the mama side and the papa side. Genetic mutations, BRCA1, BRCA2 gene mutations with female breast cancer, only BRCA2 mutation with male breast cancer. And the estrogen exposure, more estrogen exposure, more chances of breast cancer, like early menarche, late menopause, nulliparous, postmenopausal obese female, hormone replacement therapy after menopause, high estrogen based OCPs taken for a long period of time, less phytoestrogens in diet. That means protective factors for breast cancer would be late menarche, early menopause, multiparity, prolonged breastfeeding, and having first child at an early age. Do not get motivated. Pathologically, if we take a look at the breast cancer, then 90% from the duct, and they can be ductal carcinoma in situ when it has not invaded the basement membrane, or most often it has invaded the basement membrane, so it's an invasive ductal carcinoma. 10% of breast cancers can be lobular. Lobular breast cancers because they are E-cadherin negative. So the cells are scattered. That is why multicentricity, bilaterality will be more common in lobular breast cancers. Earlier, lobular breast cancers were also classified as in situ and invasive, but now this lobular carcinoma in situ, a recent change is, it is not considered as cancer, but it is considered as a lesion with high risk of cancer. And sometimes we find mucin-filled cells, signet ring cells, mucinous breast cancer, signet ring cells. This indicate that this cancer is having poor prognosis, and these can be found in both lobular as well as ductal breast cancers, but more often in the lobular breast cancer. And these are having poor prognosis. We can do Bloom-Richardson grading for breast cancers based on PMT, that is pleomorphism, mitotic trait, and tibial formation, through which we can classify the breast cancer whether it's well differentiated, moderately differentiated, or poorly differentiated. If we look at the ductal breast cancers, nowadays they say that there is no special type of ductal breast cancer. It can grow in any form. It can be colloid papillary tubular, which have better prognosis. It can be flower-like medullary, or it can be inflammatory. Inflammatory has the worst prognosis. There is a Van Nuys classification which can be done for ductal carcinoma in situ, and this comprises of the tumor size, the margin which the surgeon has taken for resection, the pathological grade of the tumor, and in the modified Van Nuys, age of the patient is also included. This is basically for prognosis of ductal carcinoma in situ, and this also helps the surgeon in deciding whether he has to just do excision, that is breast conservative surgery, or he has to do a mastectomy. So that is the use of Van Nuys classification for ductal carcinoma in situ. But in our FMG exam till now, we have not seen a question from this. Right. If we look at how breast cancer patients can present to us, most commonly presents with a lump in the upper outer quadrant of the breast, and cancerous lumps. They are usually hard in consistency, they are irregular, they may be fixed to the underlying or the overlying structures, they may be involving the lymph nodes. If they are involving the suspensory ligament or Cooper's ligament, we can find indrawing or dimpling of the skin. Now, if the examiner says indrawing or dimpling, now this means one Cooper ligament is involved. And if suppose the examiner says puckering or tethering, puckering or tethering of the skin, then it means multiple Cooper's ligaments are involved. And because this is just involvement of the ligament inside the breast, this indrawing or dimpling or puckering or tethering does not mean that cancer has gone into the skin. So this indrawing or dimpling or puckering or tethering, it is not T4B. Right. There may be circumferential retraction of the nipple, there may be bleeding from the nipple, and overlying skin can be involved in breast cancer. That can be seen as pewdy orange appearance or orange peel appearance. There can be satellite nodules, or there can be skin ulcerations. Now in pewdy orange, basically the cancer cells, they block the superficial subdermal lymphatics of the skin, giving this orange peel appearance. That means cancer has gone into the skin, so it is T4B. If this is associated with redness also, then it becomes inflammatory cancer, that is T4D. However, the latest edition of Bailey has created a little confusion. If less than 1/3 surface area of the breast is involved with pewdy orange, it is T4B. However, if more than 1/3 surface area of the breast is involved associated with redness, then it is T4D. Right. But for all practical purposes, if it is pewdy orange, no redness, T4B. If it is pewdy orange with redness or maybe just redness, then it is T4D. And this pewdy orange is because of blockade of superficial subdermal lymphatics of the skin. There may be patient presenting with lymphedema. In lymphedema, because of blockade of the axillary lymph nodes, lymph get collected in the upper limb, causing this lymphedema. Now, this lymphedema sometimes can complicate to lymphangiosarcoma. In lymphangiosarcoma, we find bluish purplish subcutaneous nodules over the forearm, and that is Steve-Travis syndrome. Sometimes we can come across a Paget's disease of breast. In Paget's disease of breast, there is erosion of the nipple due to intraductal spread of cancer cells, and these cancer cells, they eat up the nipple. That is Paget's disease of the breast. It is not a eczema. If we look at the spread of breast cancer, local lymphatic blood. Locally, cancer can go in the front towards the skin, involve the skin, or cancer can go at the back involving the pectoralis fascia, pectoralis major muscle, pectoralis minor muscle. It can involve the ribs and the intercostal muscles. Remember, involvement of pectoralis major minor muscle is not considered as chest wall involvement. But when the cancer has gone into the ribs or in the intercostal muscles, then we say cancer has gone to the chest wall. Through lymphatics, majority of the breast cancer goes to the axillary lymph nodes. 20% of the breast cancer, especially in the medial posterior part of the breast, goes to the internal mammary lymph nodes. And through blood, most commonly it goes to bones, to the same lumbar vertebra like prostate cancer, through the same Betson's vertebral plexus of veins, where the bony metastasis can be both osteoclastic as well as osteoblastic. Right, just a moment. Now, how to approach a breast cancer patient? Patient presents with a breast lump in the breast in a female who is more than 25 years of age. The standard guidelines, triple assessment, CRP, C clinical, R radiological, P pathological. In clinical, we have to take a detailed history and do a detailed clinical examination. In radiology, we do ultrasound less than 40 years, mammography after 40 years. But in high-risk cases, mammography can be done after 30 years of age. In pathology, we can do ultrasound-guided FNAC or maybe ultrasound-guided needle biopsy. The investigation of choice to diagnose the breast cancer would be needle biopsy. When we are doing mammography, then if we find irregular, spiculated, spiky, kantedar microcalcification, then it goes in favor of malignancy. And why mammography is not done in young females? Because young female breast is more dense and glandular, and we can miss some lesion in the breast on mammography in young female. But old female breasts are less dense and glandular, and we can easily see the lesion on mammography in less dense and glandular breast. That is why we say that mammography should be done after 40 years of age. This is how ultrasound guided needle biopsy is done. The ultrasound probe and the needle is going like this. And here we can see the inside story. This lesion, what you are seeing, this is the hypoechoic lesion, and here this is the needle which you are passing inside, and this is going to show the cancer. Right. For staging purpose, if you want to know about the involvement of pectoralis major muscles, major or minor muscles, then we do MRI. For metastasis, we do a PET scan. MRI is also the investigation of choice for breast with implants. MRI is also the investigation of choice to differentiate between the scar and the recurrence stories. Once all the investigations are done, we come to know about how far the cancer has spread, and we can do the staging. 2, 2 to 5, more than 5, any size, chest, skin, both inflammatory, mobile, fixed, internal memory, axillary plus apical, axillary plus internal memory, and supraclavicular. Now T1 stage, that is up to 2 centimeters in size, in Western countries, on screening, we may come to know even very small lesions inside the breast, maybe a 1 centimeter lesions can also be picked. So T1 stage can further be subdivided into uh, T1 micro, T1A, T1B, T1C. Like if up to 1 millimeter in size, this is T1 micro. More than 1 millimeter to 5 millimeter will be T1A. More than 5 millimeter to 10 millimeter will be T1B. More than 1 centimeter up to 2 centimeter will be T1C. Lymph node staging is done for ipsilateral lymph nodes. Bilateral or contralateral lymph node involved in breast cancer will be metastasis, and M1 is distant metastasis. Based on this TNM, we can classify the breast cancer into early breast cancer, locally advanced breast cancer, and metastatic cancer. Now, early breast cancer, this is T1, T2 or N0, N1, but M0. Locally advanced T3 or T4, N2 or N3, M0. And metastatic, it is any T or any N, but M1. In metastatic breast cancers, if the cancer has gone maybe to the vertebra, maybe to the lungs, maybe to liver, maybe to brain, now we'll not be able to cure these patients. So we do palliative treatment in the form of simple mastectomy. However, for early breast cancer and locally advanced breast cancer, we can do the treatment nicely. We can cure these patients. And for this, we have got 5 options to fight against breast cancer: surgery, chemo, radio, hormonal, and targeted therapy. Surgery is the mainstay of treatment, where we have the options of doing a breast conservative surgery, where we just remove the lump along with a 1 centimeter margin, but we have to give adjuvant radiotherapy as mandatory whenever we are doing breast conservative surgery. We can do simple mastectomy, that is simply removal of the breast. We can do modified radical mastectomy, where we remove the breast along with the pectoralis fascia plus the lymph nodes. A radical mastectomy, where we used to remove the breast, pectoralis fascia, pectoralis major, pectoralis minor muscle along with the lymph nodes, is no more done now. In chemotherapy, we can give ACT or CMF regimes. CAF regime can also be used. ACT is adriamycin, cyclophosphamide, and taxanes. CMF is cyclophosphamide, methotrexate, and 5-FU. We can use CAF also, cyclophosphamide, adriamycin, and 5-FU. Radiotherapy is a method to local control the tumor. Hormonal therapy should be given in all those patients where the estrogen receptors, progesterone receptors are positive on the cancer cells, cancer tissue. That means the culprit for this breast cancer is estrogen. So in these patients where estrogen, progesterone receptors are positive, we give hormonal therapy as anti-estrogens. In premenopausal females, because the estrogen load is high, we give selective estrogen receptor modulator tamoxifen, which is given as 20 milligram once a day for 5 to 10 years. If it's a low risk patient, then for 5 years, high risk patient for 10 years. But postmenopausal females, we don't use tamoxifen, we prefer using aromatase inhibitors, because the reason for estrogen in postmenopausal female will be aromatization in the body fat. So there we use aromatase inhibitors like anastrozole, letrozole, and so on. Targeted therapy, which is targeted against the HER2 gene, this is trastuzumab or pertuzumab. Trastuzumab is marketed by the name of Herceptin. When you will be seeing the case sheets, you will be seeing words like NAST, NACT and all. NAST is neoadjuvant systemic therapy. NACT is neoadjuvant chemotherapy. Now, whenever we are doing breast conservation surgery, we are doing a lumpectomy with 1 centimeter margin and we are giving adjuvant radiotherapy. We have to restore the architecture of the breast by either volume replacement or maybe volume displacement. Sentinel lymph node biopsy will be useful in those cases of breast cancer where before the operation, lymph nodes were not involved in breast cancer. So in these cases, before surgery, maybe 1 hour before surgery, the surgeon can inject a coloring agent around the tumor, peritumoral or maybe subareolar. And this coloring agent will be going through the lymphatics and will make the lymph nodes colored. Now, at the time of operation, surgeon will harvest some of the lymph nodes and send to the pathologist and will ask the pathologist that within 45 minutes, you have to tell me whether those lymph nodes which I have sent, they are having cancer cells or not. If there are no cancer cells in those lymph node removal is not required. But if these lymph nodes are having cancer cells, then we have to do the lymph node removal as well. The dye which can be used in sentinel lymph node biopsy can be a radioisotope dye or a non-radioisotope dye, like methylene blue with radioisotope technetium-99 labeled albumin or sulfur colloid. This can be used, or fluorescein or indocyanine green, which is a non-radioisotope dye, can be used. Whenever we are doing mastectomy, whether it's simple mastectomy or modified radical mastectomy, like this chest x-ray is showing us that on this side, right side, we are seeing the breast shadow, but left side, we are not seeing the breast shadow. So this is a post-mastectomy x-ray. Now, whenever we are doing mastectomy, some patients may wish for breast reconstruction. And this breast reconstruction, most often it is done with silicone gel. However, various muscle flaps can be used, like we can use latissimus dorsi, we can use transverse abdominis, rectus abdominis muscle flap, we can use DIP, deep inferior epigastric perforator flap, like this DIP is commonly used in UK, and the breast reconstruction can be done. For prognosis of breast cancer, we use a Nottingham Prognostic Index. This depends on stage of the cancer, that is TNM, and in this TNM, lymph node status becomes the most important. We can also do a molecular prognostic classification for breast cancer. If ER/PR are positive, that means it's a estrogen story breast cancer. We can give anti-estrogens to this patient, which can help in preventing the recurrence. The presence of estrogen progesterone receptors is a good prognostic factor. If HER2/neu gene is present, then it's a bad gene. The cell proliferation rate is quite high, and this is a poor prognostic factor. Ki67 is a cellular proliferation marker. If the value of Ki67 is high, it is poor prognostic marker. So, the best prognosis breast cancer will be if estrogen progesterone receptors are positive, HER2/neu is negative, and Ki67 is low. And that is what is luminal A. ER/PR positive, HER2/neu negative, and Ki67 low. That is why luminal A has the best prognosis. The difference between luminal A and luminal B is Ki67. If ER/PR positive, HER2/neu negative, and Ki67 high, that is luminal B. Earlier it was thought to be triple positive, but now no, it is same as luminal A with the difference of Ki67. HER2/neu enriched, where ER/PR are negative, HER2/neu is positive, and Ki67 is high, so it is having poor prognosis. Basal is a triple negative. ER/PR, HER2/neu, all three are negative, and Ki67 is high. Claudine low, where we don't use Ki67, we use Claudine marker. So it is a triple negative, ER/PR, HER2/neu negative. Instead of Ki67, we are just going for Claudine. Which patients should require genetic evaluation, or which patient's family should require genetic evaluation, so that we can come to know that whether the chances of breast cancer in the family are high or not. For example, if breast cancer game is not a estrogen game but a genetic mutation game, then definitely genetic analysis should be done for the family. Now, if a lady presents with breast cancer less than 50 years of age, more chances of genetic mutation. Triple negative, ER/PR negative, less than 60 years of age, more chances. 2 breast cancer primaries. Male breast cancer, no story of estrogen. That means gene game. Breast cancer at any age, but if there are too many cancers in the family, maybe 2 or more relatives affected with breast cancer, or maybe 1 or more relative affected with breast cancer less than 50 years of age, or maybe invasive ovarian cancer in the family, or maybe pancreatic, prostate, or maybe male breast cancer in the family, then also genetic evaluation should be done. Generally, if it is just a postmenopausal female with positive estrogen progesterone receptors, there is no need to get the genetic analysis done. So thank you very much for your patience. This is about the revision for oncosurgery. Now, if we revise this oncosurgery with the closed eyes, we'll be talking about GI cancers, urinary cancers, thyroid and breast cancer. First, GI cancers, oral cancer, squamous cell carcinoma, tobacco chewing, most common site gingivobuccal sulcus buccal mucosa in India, western, lateral border of the tongue, middle 1/3. Pre-malignant lesions, leukoplakia, erythroplakia. Erythroplakia, 17 times more chances of cancer than leukoplakia, so it should always be biopsied. Area near all the natural openings of the body. Human papilloma virus is also a major culprit, like we know about cervical cancer, anal cancer, penile cancer, same way oral cancer. And even esophageal cancer can sometimes be linked with this human papilloma virus, but oral cancer will be more often linked with HPV. Prognosis of cancer generally depends on the stage of cancer, that is TNM, wherein lymph node status is the most important. In oral cancers, prognosis depends on the stage, especially the lymph node status. Prognosis depends on the site of the cancer, like cancers at the commissures, they have poor prognosis. Prognosis depends on the depth of cancer. Deeper the cancer, poorer the prognosis. Duration of the cancer is not directly related to prognosis, but it can have some impact. Esophageal cancer, most commonly it's a squamous cell carcinoma in the upper 2/3, especially the middle 1/3, while Western countries it is the lower 1/3 adenocarcinoma. Risk factors, smoking alcohol, smoked food, betel nut liquid, GRD Barrett's esophagus, Ecclesia cardia, Zenkus diverticulum, human papilloma virus, radiation exposure, Tylosis palmaris plantaris, Plummer-Vinson syndrome, Pedersen-Brown-Kelly syndrome, iron deficiency anemia, polionychia, glossitis, esophageal webs, upper esophagus, cervical esophagus, commonly seen in middle-aged females, squamous cell carcinoma in the post-cricoid. Pathologically grows as a polyp, clinically presents as dysphagia, initially for solids, gradually for both solids, liquids, regurgitation, aspiration, pulmonary complications, hoarseness of voice due to involvement of recurrent laryngeal nerve, anorexia, weight loss. First investigation, if patient comes with dysphagia and we are not suspecting cancer, will be barium swallow. If we are suspecting cancer, we can do endoscopy and biopsy. So if there is just dysphagia, we do a barium swallow, filling defect, rat tail appearance. Rat tail can be seen in ecclesia also, but better answer will be cancer. If both is there in the option, then both. We can find a apple core appearance also, though it is more commonly seen in colon cancer on barium enema. But esophageal cancer, barium swallow, we can find a apple core appearance. Now, investigation of choice to diagnose esophageal cancer will be upper GI endoscopy and biopsy. To stage the esophageal cancer, CECT. For depth of tumor, endoscopic ultrasound. For metastasis, PET scan. Staging, submucosa, muscle, adventitia, adjacent organs, pleura, pericardium, diaphragm, trachea, bone, aorta. T1, T2, T3, T4A, T4B. Lymph node staging, 1 to 2, 3 to 6, 7 or more than 7. N1, N2, N3. M1, metastasis. We can use various prefixes and suffixes. Prefix, if we are using C, demonstrate clinical stage. Y, staging after neoadjuvant therapy. P is pathological staging. Suffix like X and 0. X, when it cannot be assessed. 0, no evidence. P0, no evidence of tumor. R0, no evidence of residual tumor. Mainstay of treatment in esophageal cancer is surgery, where we have to take a proximal margin of 10 centimeter, distal margin 5 centimeter. So we actually land up in doing a transthoracic total esophagectomy with esophageal reconstruction using stomach. That is Ivor-Lewis operation. Complications, early complication, anastomotic leak, pulmonary complications, late complication, stricture at the anastomotic site. Chemotherapy used in esophageal cancer, 5-FU, cisplatin. Any therapy given before the main therapy, neoadjuvant. Any therapy given after main therapy, adjuvant. Stomach cancer, adenocarcinoma, most commonly pre-pyloric, Western countries, cardia. Risk factors, smoking, alcohol, smoked food, canned food, less vitamins and antioxidants, salt, pickle. Helicobacter pylori is the main culprit. Epstein-Barr virus. Type A gastritis, atrophic autoimmune gastritis, Meniere's disease, reflux gastritis, that is alkaline gastritis, intestinal metaplasia, gastric ulcer, adenomatous polyp, mutations in P53, SMARCA1, ROA. Pathologically, a diffuse gastric cancer gives that leather bottle stomach, Leonitis plastica. Pathologically, we can classify into early advanced, early by Japanese, advanced by Boardman. If only mucosa, submucosa is involved, early. If mucosa, submucosa with muscle involvement is advanced. Lymph node involvement does not decide early or advanced. Clinically, patients can present with melena or hematemesis, epigastric mass, anorexia, weight loss. Causal sign in cancers is migratory thrombophlebitis, and most commonly seen in pancreatic cancer, can be seen in stomach cancer. Spread, local lymphatic blood and transcoelomic, that is direct peritoneal spread. Local spread, proximal stomach cancer goes to spleen, distal stomach cancer goes to pancreas. Lymphatic spread, foregut celiac, midgut superior mesenteric, hindgut inferior mesenteric. So stomach cancer, celiac. Stomach cancer can also involve the left supraclavicular lymph node, that is Virchow's node or Troisius sign, can involve the anterior axillary lymph node, that is Irish node. Through blood, liver, lungs, and transcoelomic or direct peritoneal cavity spread. If tumor deposits are seen on the peritoneal surface, these are peritoneal deposits or peritoneal seedlings. Periumbilical tumor deposits, Sister Mary Joseph nodule. Tumor deposits on the functional ovary, Krukenberg tumor. Tumor deposits on the anterior rectal wall, Blummer's shelf. If patient presents with melena, first stool for occult blood for malignant cells for RBC, and if it is positive, then we do upper GI endoscopy and biopsy. Epigastric mass, first we do ultrasound, tumor in the stomach, upper GI endoscopy and biopsy. Investigation of choice to diagnose the cancer is upper GI endoscopy and biopsy. For staging of stomach cancer, CECT, but for depth of tumor, endoscopic ultrasound. Metastasis PET scan, where the isotope used is 18F FDG, that is fluorine fluorodeoxyglucose, half-life 120 minutes. Based on this, we can do the staging. Submucosa, muscle, subserosa, perforate the serosa, adjacent organs. 1 to 2, 3 to 6, 7 or more than 7, metastasis. T1, T2, T3, T4A, T4B, N1, N2, N3, M1. The treatment for stomach cancer, proximal stomach cancer, total gastrectomy with splenectomy to achieve adequate lymphatic clearance. Distal stomach cancers, partial or subtotal gastrectomy. Colorectal cancers, most commonly adenocarcinoma, most common rectosigmoid area. Risk factors, red meat, animal fat, low fiber, less vitamins, antioxidants, smoking, alcohol, inflammatory bowel disease, ulcerative colitis, more risk than Crohn's, polycystectomy, radiation exposure, genetic mutation in the APC gene, various polyps like adenomatous polyps have more chances of colon cancer, familial adenomatous polyposis, which can be associated with Gardner syndrome and Turcot syndrome. Lynch syndrome, that is hereditary non-polyposis colon cancer associated with MMR gene mutation. Familial adenomatous polyposis, autosomal dominant, APC gene mutation. 50% of patients we have congenital hypertrophy of retinal pigment epithelium. More than 100 adenomatous polyps diagnostic of FAP. If FAP is associated with epidermoid cyst and desmoid tumors, that is Gardner syndrome. FAP associated with brain tumors, it is Turcot syndrome. Peutz-Jeghers syndrome is familial hematomatous polyposis, where there are multiple juvenile polyps in the intestine like jejunum and associated with melanin pigmentation of the lips, buccal mucosa, hands and forearms. Now, clinically, right-sided colon cancers, pathologically and clinically, right-sided colon cancers, they usually ulcerate, so present with bleeding. Left colon cancers are usually annular, so they obstruct. Rectal cancer most commonly presents with bleeding per rectum. So most common clinical presentation of colorectal cancer is bleeding per rectum, whether it's right colon cancer or left colon cancer. If it is spreading through blood, it will be going through the superior and inferior mesenteric vein into the portal vein into the liver. 33% of colorectal cancer patients, by the time they come to us, they already have liver metastasis. Patient with bleeding per rectum, suspicious of colorectal cancer, do a whole colonoscopy and biopsy. For screening, we do colonoscopy every 10 years. Barium enema can show apple core appearance in colon cancer. For staging of colon cancer, we do CCT. For staging of rectal anal cancers, we do MRI. And for metastasis, PET scan. TNM staging, submucosa, muscle, subserosa, adjacent organs, 1, 2, 3, 4 or more than 4, lymph nodes, and metastasis, T1, T2, T3, T4, N1, N2, M1. Treatment, surgery is the mainstay. For colon cancers, 5 cm margin, rectal cancer, 2 cm margin. In rectal cancer, even if we get 1 cm distal margin, that is considered as adequate. Right colon cancer, right hemicolectomy. Left colon cancer, left hemicolectomy. Right colon cancer more towards the hepatic flexure of colon, extended right hemicolectomy. Rectal cancer, upper 1/3 rectum, anterior resection, middle 1/3 low anterior resection. Lower 1/3 of rectal cancers, endoscopic circular stapler sphincter preserving surgery. If sphincter cannot be preserved, then abdominoperineal resection with permanent sigmoid colostomy. Staging of colon cancer depends on the stage, where lymph node status is important. Anal cancers associated with human papilloma virus, the squamous cell carcinomas, and the treatment is Negro regime, chemo plus radio, chemo radiation. The chemotherapy used in colorectal cancer, we can use 5-FU and oxaliplatin. Targeted therapy in rectal cancer is cetuximab. Gallbladder cancers, most commonly seen in the fundus, adenocarcinoma, risk factor gallstone, typhoid carrier, porcelain gallbladder, adenomatous polyps more than 1 cm in size. Gallbladder cancer can present with cholecystitis or maybe right hypochondrial mass or jaundice. Investigation of choice is CCT, and treatment is radical cholecystectomy, removal of gallbladder along with the lymph nodes. Pancreatic cancer, most commonly it is the head pancreatic cancer. Second is the periampullary cancer. They are adenocarcinomas. Risk factors: smoking, diabetes, chronic pancreatitis, and hereditary. Now, in head pancreatic cancers and periampullary, both presents with jaundice, but there is a difference. Head pancreatic cancer, jaundice will be late, but if it develops, it will be progressive. It will keep on increasing. Periampullary cancers, jaundice will be early, and it may be waxing and waning type. There is marked weight loss in pancreatic cancers, and Courvoisier's law is there in pancreatic cancer, which says that gallbladder will always be palpable if CVD obstruction is because of cancer. But gallbladder may not always be palpable if CVD obstruction is due to stone. Because of recurrent cholecystitis, gallbladder may be narrow contracted if it is a stone story. Investigation of choice for head pancreatic cancer, CCT. If endoscopic ultrasound guided biopsy is there, Then CCT is the first option. Endoscopic ultrasound guided biopsy is the second option. For periampullary cancers, no controversies, ERCP and biopsy. Tumor marker for pancreatic cancer, CA99. Second tumor marker, CA, carcinoembryonic antigen. Tumor marker for colon cancer, CA, carcinoembryonic antigen. Treatment of choice for pancreatic cancer, pylorus preserving pancreaticoduodenectomy. Earlier, we were not preserving the pylorus. That was a Whipple's operation, triple bypass operation, pancreaticojejunostomy, hepaticojejunostomy, gastrojejunostomy. Now, what we are doing is pancreaticojejunostomy, hepaticojejunostomy, and pylojejunostomy. Other tumors in GIT, like there can be GIST, which is not originating from the mucosa, but from the supportive tissue of mucosa, maybe submucosa or muscle. And this can occur anywhere in the GIT. 50% of GIST occur in the stomach. Second commonest site is the ileum. They originate from interstitial cell of Cajal associated with c-KIT gene overexpression of CD117. If GIST becomes malignant, because it is not the game of mucosa, it is the game of connective tissue, so it will be a sarcoma. Sarcoma does not spread via lymphatics, so lymph node removal is not required. So treatment for GIST in the stomach will be subtotal gastrectomy or a partial gastrectomy. And if GIST is massive, recurrent or malignant, then we have to give imatinib, marketed by the name of Gleevec, for the whole life. Gastrinoma or Zollinger-Ellison syndrome. This is a tumor seen in the gastrinoma triangle or triangle of Saro, which is bounded superiorly by the junction of cystic duct and the CBD, inferiorly second, third part of duodenum, medially neck and body of the pancreas. Can occur in the first part of duodenum or maybe in the second part of the duodenum and the head of the pancreas. This or can be autosomal dominant, associated with MEN1 syndrome, multiple endocrine neoplasia 1 syndrome, can be associated with non-beta islet cell tumor of the pancreas. This tumor will produce gastrin. Gastrin will stimulate the parietal cell to produce huge amount of acid. So we not only see ulcers in the stomach duodenum, but we see ulcers here and there in the intestine as well, and patient presents with abdominal pain. We can do some lab tests to diagnose these gastrinomas. Like the best lab test now is a fasting serum gastrin level. If it is more than 10 times the normal and the stomach pH is less than 2, it is diagnostic. Secretin provocative test, if we find serum gastrin more than 110 picogram per ml, that is also suggestive. Radiological investigation of choice for gastrinoma, this is 68 gallium somatostatin analog PET scan. We can do CCT, we can do endoscopic ultrasound also to diagnose these gastrinomas, and the treatment of choice for gastrinoma is aggressive PPI. If gastrinoma is more than 2 centimeter, we can do removal of the tumor as well. Carcinoid tumor, these are neuroendocrine tumors, can occur anywhere in the body, maybe in the bronchus, respiratory tract, or maybe in the GI tract or anywhere else in the body. In the GI carcinoids, most common site is the appendix. Earlier it was ileum. Now these carcinoid tumors, they originate from the argentafin cells, that is Kulczycki cells in the crypts of liverpool. And they produce substances like 5-hydroxytryptamine serotonin, which can lead to symptoms like cyanosis, flushing, diarrhea, borborygmi, asthmatic attacks. There will be raised levels of 5-hydroxytryptamine serotonin. We find raised levels of 5-hydroxyindolestic acid in urine. Plasma marker is chromogranin A. And the treatment of choice for appendiceal carcinoids, if the tumor is less than 2 centimeter size, no cecal wall involvement, no lymph node involvement, just do appendicectomy. But if the tumor in the appendix is more than 2 centimeter in size, involving the cecal wall or the renal lymph nodes, then do a right hemicolectomy. Treatment for ileal carcinoids, it is somatostatin analog as the first line treatment. Second line treatment will be PRRT, peptide receptor radionuclide therapy. Then urinary malignancies, kidney, bladder, prostate, penis, testis. In kidney, in babies, Wilms tumor, nephroblastoma below 5 years of age, most common tumor of childhood, Wilms tumor. Associated with inactivation of Wilms tumor suppressor gene WT1, which can be associated with Weger-Dennis-Rush syndrome. Inactivation of W2T2 can be associated with Beckwith-Wiedemann syndrome. Generally, Wilms tumor are seen at the lower pole of the kidney, presents as abdominal mass in the lumbar region, pyrexia, or sometimes maybe hematuria. Investigation of choice will be CCT, where we can see a claw sign, and the treatment of choice: stage 1, stage 2 surgery plus chemo, stage 3, stage 4 surgery, chemo, radio. Surgery, radical nephrectomy, remove the kidney with the lymph node. Adult kidney cancer or hypernephroma. This is adenocarcinoma, most commonly from proximal convoluted tubular epithelium. Most commonly it is a clear cell type. And the most important risk factor for kidney bladder cancer is smoking. However, kidney bladder cancers are also considered as occupational or industrial cancers. Like people who are working in maybe textile, rubber, polish, painting industry, aniline dyes, naphthylamine, benzene, azo dyes, they are responsible. Long-standing stone in the kidney, long-term analgesic abuse, and a von Hippel-Lindau syndrome associated with adult kidney cancer or hypernephroma, which is associated with deletion of short arm, which is associated with VHL gene, and this is on the short arm of third chromosome 3p. Adult kidney cancer or hypernephroma can present as painless hematuria. Kidney and bladder cancer both commonly present with painless hematuria. However, sometimes there can be pain, sometimes there can be abdominal mass. Left-sided kidney cancers can present with left-sided varicoceles. Kidney cancer can produce substances which can lead to paraneoplastic syndromes like hypercalcemia, erythrocytosis, and raised ESR. A patient presenting with painless hematuria suspected of kidney or bladder cancer, first we do urine cytology to rule out malignant cells. If malignant cells are present, bladder cancer will be more common than kidney cancers, so our next step will be cystoscopy. But if it is a kidney cancer, cystoscopy will be negative, so we do a CECT, which is the investigation of choice for kidney cancer. In the treatment, kidney cancer mainstay treatment is surgery, because kidney cancer don't respond to chemo and radiotherapy. Immunotherapy with BCG has definitely been tried in kidney and bladder cancers. For kidney cancer, if we look at surgery, we have two options: partial nephrectomy or nephron sparing surgery, and radical nephrectomy, removal of the kidney with the lymph nodes. If the tumor is less than 4 centimeters, or in selected cases 4 to less than 7 centimeter, or patient having single kidney having cancer, or both the kidneys having cancers, or kidney function is impaired, then we try to preserve as many nephrons as possible, partial nephrectomy. But if nothing is there, then radical nephrectomy. Like in general, tumor less than 4 centimeter in the kidney, partial; tumor 4 or more than 4 centimeter in the kidney, radical nephrectomy. Bladder cancer, most commonly it's a transitional cell carcinoma, 90 to 95% of the times. Squamous cell carcinoma in the bladder related to parasite Schistosoma hematobium, which causes schistosomiasis or bilharzisis. Adenocarcinoma in the bladder related to congenital bladder diverticulum. So this can be seen at the dome or fundus of the bladder, midline, anterosuperiorly. Risk factor: smoking and various dyes, chemicals, just like kidney cancer. Pathologically, majority of bladder cancers grow as papillary tumors, and 70% of bladder cancers are superficial, that is non-muscle invasive. That means they are just involving the mucosa and the submucosa, not going into the muscle. However, 25% can be muscle invasive, while 5% can be flat but multicentric, and they have poor prognosis. So most commonly superficial bladder cancer, that is non-muscle invasive bladder cancer, most commonly presents with painless hematuria. First investigation, urine cytology for malignant cells. If that is positive, suspecting bladder cancer, do cystoscopy. You can see the tumor nicely on cystoscopy, take a biopsy. And transitional cell carcinoma, staging, MRI. In the treatment, if it's a superficial bladder cancer, then do TURBT, transurethral resection of the bladder tumor. And after that, give intravesical therapy, either intravesical chemotherapy with mitomycin C or intravesical immunotherapy with BCG. If it is a muscle invasive bladder cancer, then first give neoadjuvant chemotherapy to downstage the bladder cancer, then do a radical cystectomy where you remove the bladder along with the prostate, cystoprostatectomy. Whenever you are removing the urinary bladder cystectomy, you can reconstruct the urinary bladder using ileum, or if not, then do a urinary diversion into a ileal or a colonic conduit. If patient is not willing for surgery in muscle invasive bladder cancer, then you can give chemotherapy and radiotherapy. Prostate cancer is the commonest cancer in elderly males. 70% of the males after 80 years of age suffer from prostate cancer. It's adenocarcinoma growing in the peripheral zone, causing enlargement of the posterior lobe. We don't know why prostate cancer occurs, but maybe androgen is the culprit, and they're very slow growing cancer. Patients generally do not have any problems. If this prostate cancer spread locally through lymphatic or through blood, locally the cancer goes upwards and laterally. So involvement of seminal vesicle occur early, but involvement of urethra is late. Through lymphatics, it's a pelvic area, pelvic organ, so pelvic lymph nodes, internal iliac lymph nodes will be involved. And before it goes to the internal iliac, it goes to the obturator lymph nodes. And through blood, prostate cancer most commonly goes to the bones, the lumbar vertebra through Betson's lumbar vertebral plexus of veins. 5 cancers in the body spread commonly to bones: P, B, K, B, T. Prostate, breast, kidney, bronchus, thyroid. Pakistan, Bharat ka bachcha tha. Bony metastasis in prostate and breast cancer, because they are hormone related, they can be osteoblastic. Generally, bony metastasis in prostate cancer are osteoblastic. In breast, they can be osteoclastic as well as osteoplastic. In both prostate and breast cancer, the bony metastases are because of Betson's vertebral plexus of veins. Now, investigation of choice to diagnose prostate cancer is a prostatic biopsy, ultrasound guided prostatic biopsy. We take 12 biopsies, which can tell us it's adenocarcinoma, and we can do a pathological grading of prostate cancer that is called as Gleason's grading. Gleason score ranges from 2 to 10. Pathological grading in breast cancer is Bloom-Richardson grading. For staging of prostate cancer, we can do MRI, that is a multiparametric MRI, and for metastasis in prostate cancer, we do a PET scan. But here we can do a PSMA scan, that is prostate specific membrane antigen scan. That is a 68 gallium PSMA scan, 68 gallium prostate specific membrane antigen PET scan. Tumor marker for prostate cancer is serum PSA. Normal value 0 to 4 nanogram per ml, more than 10 suspicious of cancer, more than 35 advanced prostatic cancer. Various uses of PSA. PSA can help us in diagnosing different pathologies of the prostate, can tell us about the disease progression, but the most important use of PSA is monitoring the response of prostate cancer treatment. Though PSA can also guide us about the recurrence of prostate cancer. In the treatment of prostate cancer, if the game is confined within the prostate, age less than 70, life expectancy more than 10 years, we can do a radical prostatectomy either by open laparoscopic or robotic surgery, or we can destroy it by external beam radiotherapy using iodine 125 or palladium 103. But if the cancer is confined within the prostate and the age is more than 70 years, where life expectancy is less than 10 years, then because it's a very slow growing cancer, it may not spread in the next 10 years. So we can do active surveillance, follow up MRI every 6 months. Why to give unnecessary complications if the cancer is not going to go beyond the prostate? However, in advanced prostatic cancers, if the prostate cancer has gone beyond the prostate, then we cannot do curative treatment, just palliative treatment, androgen ablation, which can be done by medicines or by surgery. In medicines, which is a better option than surgical castration, we can give LHRH agonist like Goserelin, Buserelin, LHRH antagonist like Degarelix, androgen receptor blockers like enzalutamide, testosterone production blockers like abiraterone. Surgical castration, bilateral subcapsular orchidectomy, removing both the testes will reduce the androgen source. Penile cancer, it's a squamous cell carcinoma. The most important risk factor is poor hygiene, smoking, human papillomavirus, long-standing genital warts, multiple sexual partners, benign intraepithelial neoplasias involving the glands, erythroplasia of Quirac involving the shaft, Bowman's disease. Generally presents as ulceroproliferative, foul-smelling growth over the penis, and inguinal lymph node enlargement is quite common. 50% of the time inguinal lymph node enlarged because of infection, 50% because of the tumor. Death in penile cancer is because of torrential bleeding, torrential hemorrhage due to erosion of the iliac or the femoral vessels by the enlarged inguinal lymph node. When the patient comes to us with a penile cancer, we can take a biopsy to diagnose the cancer, for staging MRI, and for metastasis PET scan. The treatment is we have to remove the tumor with a 2 centimeter margin. Now, if after taking 2 centimeter margin, you can preserve 2 or more than 2 centimeter of penile stump, to a partial penectomy. If after taking 2 centimeter margin, you cannot preserve even 2 centimeter of penile stump, to a total penectomy with perineal urethrostomy. For inguinal lymph nodes, because 50% of the time they'll be enlarged due to infection, so you can give a 3-week antibiotic course. If it was because of infection, they will subside, but if it was because of tumor, they will persist, and then we have to do surgical removal for these inguinal lymph nodes. Testicular cancer is the most common cancer in young males, and it is a seminoma. However, in the testis, we can find germ cell tumors, which can be seminomatous, non-seminomatous like yolk sac tumors, embryonal cell carcinoma, and teratomas. Most common cause of testicular cancer is undescended testis. Patient present with scrotal enlargement, heaviness in the scrotum. Epigastric lump indicate prepariotic lymph node enlargement. Hemoptysis indicate pulmonary metastasis, which are seen as rounded cannonball deposits on X-ray. Right testicular cancer goes to interaortocaval lymph nodes. Left testicular cancer goes to left paraortic lymph nodes. Seminoma spread more commonly by lymphatics. Teratoma spread more commonly by blood. Patient presenting with scrotal enlargement, 30 years old suppose, transillumination. If transillumination is negative, it can be tumor. Don't do transscrotal FNAC or biopsy, that is absolutely contraindicated. Get the ultrasound of the scrotum done to rule out whether it is hydrocele or testicular cancer. You can take the help of tumor markers if it looks to be a tumor, like alpha-fetoprotein yolk sac tumors, HCG choriocarcinomas, lactate dehydrogenase placental alkaline phosphatase seminomas. However, you also have to see the prepariotic lymph nodes, so CECT is the investigation of choice for testicular cancer. And based on this, we can do the staging, like if the game is confined within the testis, stage 1. If the game goes to lymph nodes below the diaphragm, stage 2, lymph nodes above the diaphragm, stage 3, metastasis, stage 4. Stage 2 can be 2A, 2B, 2C, up to 2 centimeters 2A, more than 2 to 5 centimeters 2B, more than 5 centimeters 2C. If the game was confined to the testis only, do a high inguinal orchidectomy. That means remove the testis along with the spermatic cord. If the game was going beyond, say into the lymph nodes, then you have to treat the lymph nodes. You have the options of giving chemotherapy. You have the option of radiotherapy in seminomas, because seminomas are radiosensitive. And you have the option of doing a surgical removal of these lymph nodes, that is retroperitoneal lymph node dissection. Out of all, best would be combination chemotherapy, BEP, bleomycin, etoposide, and platinum-based cisplatin. Because seminomas spread through lymphatic teratomas, so blood seminomas have a better prognosis, and seminomas are radiosensitive. Thyroid cancers, majority, this is a common endocrine malignancy, majority originate from the follicle, and majority are papillary thyroid cancers. There can be follicular thyroid cancers also. Malignancy originating from the parafollicular C cells is medullary thyroid cancer. Metastasis can come to thyroid from kidney and breast cancers. Most common thyroid cancer is papillary thyroid cancer. These are differentiated thyroid cancers, papillary and follicular. If we see the difference between papillary and follicular, papillary is much more common. Papillary presents in slightly younger age group, less than 40 to 50, follicular usually after 50 years. The reason for papillary thyroid cancer, radiation to the neck, especially if a child is exposed to multiple X-ray CT scans below 5 years of age of the neck. Thyroglossal cyst can cause papillary thyroid cancer. Follicular thyroid cancer associated with long-standing endemic coitus. Pathologically, pale orphan empty-eyed nuclei, papillary thyroid cancer. Pneumoma bodies, papillary thyroid cancer. Pneumoma bodies can be seen in other tumors like PSM, papillary thyroid cancer, papillary renal cell carcinoma, pituitary adenoma, serous cyst adenoma of ovaries, salivary adenoma, meningioma. Follicular thyroid cancers, they are encapsulated. FNAC cannot distinguish between follicular adenoma and follicular carcinoma because FNAC cannot comment about capsular and vascular invasion. Most often, whether it's papillary or follicular, will present with a neck swelling. We do ultrasound guided FNAC. Tumor marker is serum thyroglobulin for both papillary and follicular. Papillary spread commonly through lymphatics, follicular through blood, so papillary have better prognosis. Tumor marker is serum thyroglobulin. The treatment would be total thyroidectomy with removal of involved lymph nodes. Medullary thyroid cancer originate not from the follicle but from the parafollicular C cell. So there is no role of TSH, no role of thyroglobulin. Pathologically, there is amyloid stroma. These medullary thyroid cancers can be autosomal dominant, associated with multiple endocrine neoplasia 2, 2A and 2B, and associated with the mutations RET proto-oncogene. Pathologically, there is amyloid stroma. Clinically, presents with a neck swelling and enlarged lymph nodes in the neck. Because medullary thyroid cancer produces substances like serotonin, so 25-30% of patients can have diarrhea. The tumor marker for medullary thyroid cancer is serum calcitonin. Second tumor marker for medullary thyroid cancer is serum CEA, carcinoembryonic antigen. And the treatment is total thyroidectomy with removal of involved lymph nodes. Whether it is papillary, follicular, or medullary thyroid cancer, the first lymph node to get involved in thyroid cancer will be the pretracheal or the level 6 lymph node. Now, neck lymph nodes can be classified into various subgroups: submental, submandibular, 1A and 1B. 2, 3, 4 is upper, middle, lower, jugulo-digastric or deep cervical lymph nodes. 5 posterior triangle lymph nodes, 6 pretracheal, and 7 mediastinal lymph nodes. 8th will be parotid story, 9th will be buccofacial, and 10th will be retroauricular and occipital lymph nodes. In head and neck malignancies, because cervical lymph nodes will be involved commonly, so apart from removing the tumor with margin various operations, if cervical lymph nodes are involved, we have to remove the cervical lymph nodes also. So there are different type of neck dissections, like radical neck dissection, where we remove 1 to 5 group of cervical lymph nodes plus sternomastoid muscle, internal jugular vein, spinal accessory nerve. Modified neck dissection is same as radical neck dissection, but with preservation of any of the sternomastoid, internal jugular or spinal accessory nerve. Selective neck dissection is same as modified neck dissection, but with preservation of any or more lymph node groups out of 1 to 5. Right. Now, breast cancer is the commonest cancer in females. It is the adenocarcinoma. Most commonly, it is invasive ductal carcinoma. Most common site is the upper outer quadrant. Least common site is the lower inner quadrant. Reason for breast cancer: familial, mama, papa, both sides. Genetic, BRCA1, BRCA2 female, only BRCA2 male. Estrogen exposure, prolonged estrogen exposure like early menarche, late menopause, nulliparity, postmenopausal obese, hormone replacement therapy after menopause, high estrogen based OCP for long periods, less phytoestrogens in diet. So protective factors: late menarche, early menopause, multiparity, prolonged breastfeeding, and having first child at an early age. Do not get motivated. Pathologically, 90% of breast cancers from the duct, which can be ductal carcinoma in situ if not invading the basement membrane, or maybe invasive ductal cancer which are invading the basement membrane. 10% are lobular breast cancers. They are E-cadherin negative, so chances of multicentricity and bilaterality are more in lobular cancers. Bilateral breast cancer is lobular breast cancer. Now, lobular carcinoma in situ, nowadays it is not considered cancer, but it's considered as a lesion with more chances of cancer. Pathologically, sometimes we find signet ring cells in the cancer. These are mucin-filled cells, and this indicate poor prognosis. Can be seen in both lobular as well as ductal breast cancers, but more often seen in lobular breast cancer. Pathological grading of breast cancer is Bloom-Richardson grading based on PMT, pleomorphism, mitotic rate, tubule formation, where we can classify them into well differentiated, moderately differentiated, and poorly differentiated. Now, pathologically, ductal breast cancers, they can grow in any form, so most common is a no special type. However, there can be colloid, papillary, tubular types which have good prognosis. Medullary type, inflammatory type will have the worst prognosis. There is a Van Nieuwes classification for ductal carcinoma in situ to tell us about the prognosis and a decision whether we should do a breast conservative surgery or a mastectomy. And this is based on the size of the tumor, the margin of resection what the surgeon has taken, the grade of the tumor, and the age of the patient. Clinically, breast cancer patients, they present with a lump, usually in the upper outer quadrant, and this is a hard irregular lump, maybe fixed to the underlying overlying structures, maybe involving the lymph nodes. We may find indrawing or dimpling of the skin. This is not because the cancer has gone into the skin, but it is due to involvement of the suspensory ligaments of the Achilles ligaments or the Cooper's ligaments. If only one Cooper ligament is involved, there is dimple in the skin or indrawing of skin. If multiple Cooper's ligaments are involved by the cancer in the breast, then it causes puckering or tethering of the skin. But skin is not involved, so it is not T4B. There may be circumferential retraction of the nipple, there may be bleeding from the nipple, and if the breast cancer goes into the skin, we can find a pudy orange appearance, we can find satellite nodules, we can find skin ulcerations. Like pudy orange is an orange peel appearance. This is due to blockade of superficial subdermal lymphatics of the skin by the cancer cells. That means cancer has gone into the skin, so this is stage T4B. However, if it is associated with redness, it becomes inflammatory, so that is T4D. Right? Bailey says, latest edition, up to 1/3 surface area of the breast involved with pudy orange, T4B. More than 1/3 surface area of the breast involved associated with redness, it is T4D. Now, apart from this, patient can present with the lymphedema of the arm. This is due to blockade of the axillary lymph nodes by the cancer cells. And this lymphedema can complicate into lymphangiosarcoma, where we can find bluish purplish nodules over the forearms, Steve Travis syndrome. Paget's disease of the breast is erosion of the nipple due to intraductal spread of the cancer cells. This is not eczema. Breast cancer can spread by 3 routes: local, lymphatic, and blood. Locally, breast cancer can go anteriorly into the skin. Posteriorly, it can go into the pectoralis fascia, pectoralis major, pectoralis minor muscle, then to the ribs and the intercostal muscles. Involvement of the skin is T4B. Involvement of pectoralis major and minor muscle does not mean chest wall. Involvement of ribs and intercostal muscle means chest wall involvement, that is T4A. Through lymphatics, majority goes to the axillary lymph nodes, but cancer in the medial posterior part goes to the internal mammary lymph nodes. And through blood, breast cancer most often goes to the bones, lumbar vertebra, through the same Batson's vertebral plexus of veins. And bony metastasis in breast cancer can be osteoclastic as well as osteoblastic. Our clinical approach: any lady presenting with a lump in the breast, and if the age is more than 25 years, the standard is triple assessment, CRP, clinical, radiological, pathological, clinical history examination, radiological ultrasound less than 40, mammo more than 40, mammo more than 30 in high-risk cases. Patho, ultrasound guided FNAC, ultrasound guided needle biopsy, investigation of choice to diagnose the breast cancer, ultrasound guided needle biopsy. On mammography, we find irregular spiculated microcalcification. It is going in favor of cancer. Young females, we don't do mammography because of density and glandularity of the breast is more, so we may miss the lesion. For staging of breast cancer, if we want to know the involvement of pectoralis major minor, we do MRI. MRI is also the investigation to study breast with implants. MRI is also the investigation to distinguish between scar and recurrence. For metastasis, we do PET scan. And based on this, we can do the staging 2, 2 to 5, more than 5, any size. Chest, skin, both inflammatory. Mobile, fixed, internal memory, axillary plus apical, axillary plus internal memory, supraclavicular, and metastasis. Bilateral or contralateral lymph node involvement indicate metastasis. We can classify the breast cancer into early breast cancer, locally advanced breast cancer, and metastatic cancer. T1, T2, N0, N1, M0. This is early. T3, T4, N2, N3, M0. This is locally advanced. Any T, any N, but M1. This is metastatic. And in metastatic breast cancers, if they've spread to distant areas, maybe lungs, liver, brain, then no curative treatment possible, just palliation, simple mastectomy. However, for early and locally advanced breast cancers, we can cure the patient completely, and we have got 5 options in the treatment. Surgery, chemo, radio, hormonal, targeted. In surgery, we can do a breast conservative surgery where we remove the lump with a 1 centimeter margin, where an adjuvant radiotherapy is a must. And after doing this breast conservative surgery, we have to restore the architecture of the breast either by volume replacement or by volume displacement. Simple mastectomy is simply removal of the breast. Modified radical mastectomy is removal of the breast along with the pectoralis fascia and the lymph nodes. Radical mastectomy is not done now. This was removal of the breast, pectoralis fascia, pectoralis major, pectoralis minor muscle plus the lymph nodes. Chemotherapy, we can use ACT, adriamycin, cyclophosphamide, taxanes. We can use CMF, cyclophosphamide, methotrexate, 5-FU. Radiation is a method for local control. Hormonal therapy will be given in all those patients where hormone receptors are positive, ER/PR positive breast cancers. In premenopausal females, because of high estrogen load, we give selective estrogen receptor modulators like tamoxifen 20 mg once a day for 5 to 10 years, low risk cases for 5 years, high risk cases for 10 years. However, postmenopausal females, the source of estrogen will be aromatization. So there we give aromatase inhibitors, anastrozole, letrozole. Targeted therapy, if HER2 new gene is positive, whether it is breast cancer or stomach cancer, then we give trastuzumab, that is Herceptin. We can give pertuzumab. When we are doing breast cancer surgeries, if suppose lymph nodes are not found to be involved in breast cancer and surgeon is planning that he is not going to remove the lymph nodes, while taking the patient for surgery, surgeon will be having an apprehension that maybe investigations are saying that lymph nodes are not involved, but by chance, if the cancer has gone into the lymph nodes and I am not removing the lymph nodes, I might leave the lymph node cancer cells behind. So to remove that apprehension, surgeon does a sentinel lymph node biopsy. 1 hour before taking the patient to the operation theater, 1 or 2 hours before, the surgeon can inject a dye, a coloring agent around the tumor, peritumoral. Or if not peritumoral, he can inject it around the areola, subareolar. This coloring agent will travel through the lymphatics and go to the lymph nodes. Now, at the time of operation, surgeon can see those colorful lymph nodes. So he can harvest 4, 5, 6 lymph nodes, send it to the pathologist at the same time when the patient is still under anesthesia. And within 30 to 45 minutes, the pathologist has to tell the surgeon whether cancer cells are present in the harvested lymph nodes or not. If there are no cancer cells in those lymph nodes, no need for lymph node removal. If pathologist says cancer cells are present in those lymph nodes, go for lymph node removal. This is the role of sentinel lymph node biopsy. And the dyes which we can use for sentinel lymph node biopsy, a radioisotope dye and a non-radioisotope dye. A radioisotope dye, that can be basically a technetium based radioisotope, albumin sulfur colloid can be used. Methylene blue with technetium labeled albumin sulfur colloid. This is a radioisotope story, or we can use a non-radioisotope, that is fluorescein or indocyanine green dye. Now in breast cancer patients, whenever we are doing mastectomy, depending on the choice of the patient, we might have to do breast reconstruction, for which most commonly we use silicone gel. However, muscle reconstructions can also be done, like latissimus dorsi flaps, transverse rectus abdominis muscle flap, DIEP, that is deep inferior epigastric perforator flap, which is more commonly used in UK. So these are the various methods for breast reconstruction. Now, prognosis of breast cancer, Nottingham Prognostic Index. Prognosis depends best on the stage, and in the stage that is TNM, it is a lymph node status. There is a molecular classification for prognosis of breast cancer. If estrogen and progesterone receptors are positive in breast cancer, that means we can give anti-estrogen therapy to this patient, so the chance of recurrence will be less. So presence of ER/PR is a good prognostic factor. But HER2/neu gene is a bad gene. Its presence is poor prognosis. Ki67 is a cellular proliferation marker. If it is high, it is a poor prognosis. That means a cancer which has got positive estrogen and progesterone receptors, negative HER2/neu, and low Ki67, that will have the best prognosis. And this is the luminal A having the best prognosis, where ER/PR are positive, HER2/neu is negative, Ki67 is low. Luminal B, the only difference is Ki67 is high. HER2/neu enriched, where ER/PR are negative, HER2/neu is positive, Ki67 is high, very poor prognosis. Basal or triple negative, where ER/PR are negative, HER2/neu is negative, and Ki67 is high. Claudine low is just like basal or triple negative, that is ER/PR negative, HER2/neu negative, but instead of Ki67, Claudine low is a marker here. Genetic analysis in breast cancer should be done in those families where we suspect that it is not the estrogen who is the culprit for breast cancer, but it is the genetic mutation which is culprit. For example, young female presenting with breast cancer may not be related to estrogen, maybe genetic story. So breast cancer less than 50 years of age, genetic analysis should be done. Triple negative breast cancer less than 60 years of age, genetic analysis should be done. 2 breast cancer primaries, genetic analysis should be done. Male breast cancer, genetic testing should be done. And if there is a very strong history of various cancers in the family, then also genetic mutation may be the culprit. Suppose 2 or more relatives are affected with breast cancer, or 1 or more relative affected at a young age with breast cancer, or maybe there is invasive ovarian, pancreatic, prostate, or male breast cancer, then genetic analysis is needed. Genetic analysis will not be needed in those females who are post-menopausal. And if hormone receptors are positive, that means it must be the game of estrogens only. No genetic analysis is needed. So thank you very much for your patience. We are done with the oncosurgery revision. God bless you all. Keep fighting hard.